Welcome everyone for this webinar on spinal tuberculosis from diagnosis to treatment. We have convener Dr. Tushar Rathod as a additional professor from KEM Hospital, Dr. Abhay Nene, eminent spine surgeon in Mumbai. So this is the WIROC pre-WIROC webinar, and these are a series of webinars for all the subspecialties in orthopedics. And this is also a pre-WIROC event to include all of us and to make us aware about the big conference which is coming up in Mumbai from 20th to 22nd December. I, Dr. Dheeraj Sonavne, I am the organizing secretary for this year's WIROC, and I welcome you all for this year's WIROC 2024 in Mumbai. Thank you very much. Over to Dr. Tushar Rathod.
Thank you, Dheeraj. This is, as you all seen, we have a wonderful series of various pre-conference WIROC workshop or the webinar which has been done. And there has been a lot of well-thought, laid-out process which has been done by Dheeraj and his team. And they have come out with topics which are of a concern to normal what we see in our practice and day-to-day as an orthopedic surgeon, what he faces in his practice. So these topics, the presentation, the case presentation, the name, they have been specifically chosen to mean that would add additional impact and knowledge to the existing our understanding about tuberculosis. Especially when we see in Mumbai, we are seeing a lot of variety of tuberculosis, multiple drug resistance, extreme drug resistance, total drug resistance. And how do you deal with that? For that, we have an esteemed panel of faculty which consists of Dr. Abhay Nene, who is going to talk about the surgical management of the tuberculosis. When do we hold our knife and when do we deal with this devil? The second is that we're going to start with Dr. Rohan Gala, our young eminent spine surgeon, who's going to talk about the clinical features and how do you come to the understanding of the various clinical features and what is their relevance in a management of tuberculosis. Second part will be the diagnosis, because nowadays we are listing various tests and this gene expert and whatnot, and I'm going to throw light on those various tests and what is the importance of microbiological diagnosis. Third, we'll have a third lecture by Dr. Shitish Chowdhury, who's going to talk about the conservative management of tuberculosis, because we always been hearing that the tuberculosis is a medical disease and we need a medical management. And I feel there's a lot of say of conservative management, so he's going to throw light. And that'll be followed by a surgical management. And after this, Dr. Bhushan Hadule, who's the assistant professor, is going to talk about the clinical case presentation scenario, and also Dr. Deepika Jain, who is a senior researcher. She's also going to show us the cases. In a panel, we have Dheeraj and other luminaries which are going to talk about and they will give their input. And I constantly encourage all the delegates to pose their questions, as well as the faculty. If they have any cross-faculty questions, please pose them. We want this to be a very interactive webinar. And without wasting much time, I'll request Dr. Rohan to start his presentation and share his screen. Thank you.
Can you all see my screen?
No.
Now?
Yes, we can see the screen.
Yes, you can see me.
So I thank Professor Dheeraj and Professor Tushar and the entire team of WIROC 24 for giving me this opportunity. And I will start with a very basic and simple, beginning to this whole webinar, which is the clinical picture as to how does one diagnose Koch's. So when you come to the clinical aspect of this disease, it is mainly dependent on the stage of it, the site of it, the age of it, and the complications and the sequelae. Now, despite all this, and despite a collective experience from all of our surgeons in Bombay, we all agree that the presentation is still variegated in today's world, apart from a few telltale signs in Koch's. So what is the onset? Now, affection to the spine is the most common manifestation of osteoarticular Koch's, but the onset is usually insidious and it progresses very slowly. What are the symptoms? Are they really specific? Because a lot of patients come very late to us. They come with non-specific back pain in the beginning, which are dealt with over-the-counter drugs, only to realize when they come with one of the complications or sequelae, because initially they present as nothing else but back pain. Yeah, certain features may result in complications coming earlier, but from the onset of this disease to its diagnosis, we usually have a window of anything between 3 weeks to 4 months. So they come with very non-specific vague symptoms to begin with. But the chronicity of illness is something which over time increases in intensity and then, leads us to one way or the other in diagnosing this. Third is constitutional symptoms. Now, I do not know how relevant is this, because if you see literature as well as, over time, I think not more than 2 to 3 out of 10 patients actually present with those classic constitutional symptoms that we address and that we highlight or reiterate whenever we are presenting cases or whenever we are talking about a clinical profile of a particular patient. Last is Koch's and Koch's history or close contact with someone who has had Koch's. Now, as per recent literature, they say that at least 20% of these patients are suffering from pulmonary Koch's in the past, or at least they are in contact, especially in the endemic areas of our city. So we have to geographically also narrow down these areas where it is so endemic that, living in high volumes, like more population density. These are the things that we have to ask, whether they are living like a large number of people living together in a very small space, whether they come from certain areas which are slum dominant or something like that. Last, night cries and stiffness. Yeah, these become very, very important to be asked, because they will help you in diagnosing at least few of the masqueraders of this disease, where like you have a spondyloarthropathy, which will be associated with some sort of an axial stiffness, or you have something like a space occupying lesion in the spine, which will have something called as a night pain. Now, sometimes we are unable as clinicians to differentiate between night pain and night cries based on the patient's history, but it is still an important red flag, I feel, to kind of go slightly more and investigate and evaluate just to find out and diagnose this disease early. One more very important thing is the immunocompetency of the patient or not. Whether the patient is immunocompromised due to its serostatus, or he's on prolonged steroids or immunosuppressants, that is also a very important a factor which will help us diagnosing these things, because it should arouse suspicion in a clinician's mind, especially in a country like India where Koch's is endemic. So these are other external manifestations of tuberculosis. So we have erythema, we have flicten, we have scrofulloderma, rupus vulgaris, and beaded vas deferens. Now, these are things which are external manifestations which may be or may not be present, but this is also something that we should have some knowledge of. So coming to the most important part, which is the complications and sequelae. Now, most of them come very late. So when do they come to us? When they have progressive back pain, which now becomes so bad that they come with some amount of instability associated with it, or they come with some sort of an abscess or a sinus, or they come with a dense neurodeficit. Just one second. Or with deformity. So where does the abscess lie? Whenever we talk about these patients, based on the anatomical location of the spine, the abscess can be anywhere, but these are the most common sites where you can find an abscess. Suppose if you have a craniocervical or a cervical pathology, then the patient may present with some sort of a dysphagia or a torticollis with retropharyngeal collection. We also have some sort of ulcers happening in the posterior triangle of the neck when the abscess percolates there. Sometimes the abscess may even trickle down to the axilla, and we may have non-specific radiculopathy occurring at that point. Abscess can present as shortness of breath when you have a mediastinitis picture when the abscess trickles down, or it can also present to you something like along the costovertebral chain, where it will irritate the costovertebral nerve there, or the costal nerve, intercostal nerve. Then the abscess will always seep down through the area of least resistance. Now that is either through the psoas muscle like a psoas abscess, or it may seep down through the Petit's triangle if it's very aggressive. Now when they trickle down even lower, it may actually go into the hip where you have the obturator twig supplying at the hip joint. And when that gets irritated, you may even manifest it on the medial aspect of your knee, which is a referred pain of these abscesses. So the abscess will always trickle down through the area of least resistance. And these are some of the common sites. Please stop me if you all have anything to add. Okay. So these are the places where the abscess usually comes down. It is the retropharyngeal space where you can have difficulty in swallowing. You can have changes. Hoarseness of voice is also very commonly found, and sometimes you can have some sort of respiratory distress, neck pain and stiffness. Believe me, apart from the Grissel syndrome, a lot of children with even a mid cervical to lower cervical abscess do present with torticollis. They do. So important diagnosis of torticollis, once you have ruled out the congenital one and a congenital sternocleidomastoid contracture, please don't hesitate to get a cervical spine X-ray at least to be done. Then comes the posterior triangle of the neck. So they may, the abscess may collect behind in the posterior aspect, which causes some sort of stiffness in the neck. Stiffness, although it is less, it is given less importance to, but in the long run, when the patient persistently nags you with something called as I'm getting stiffness of my neck, stiffness, it is something that we have to be alert with, especially when you have those axial spondyloarthropathies, sacroiliitis. I mean, sacroiliitis is one place where, that axial stiffness, which we think that is relieved on ambulation, a lot of patients come back eventually with a small lesion along the sacroiliac joint with some effusion, just to find out that once we call the IR and then, we diagnose Koch's. But spondyloarthropathy, stiffness of, the point I was trying to make is that stiffness, when the patient repetitively complains of that, should alert a clinician as to why is it happening and should not be hesitant in investigating these cases further. So now you have something called as paravertebral and mediastinal region collections, where you can have chest pain, where you can have dyspnea, and they almost mimic symptoms of mediastinal space occupying lesions also. Now the Petit's triangle is a triangle which is situated in the lower back, which is, as you know, that bordered by the iliac crest, the lati dorsi, and the external oblique. More aggressive abscess collections not only trickle down the psoas, but they will also breach this area. And you can have like these collections, as you can see in the picture below, that these are the places where you can have collections and cold abscesses also. Now coming to the psoas muscle, one of the main important, how do I say, when the abscess trickles down the psoas, it actually causes a psoas muscle spasm. And this is one of the most important cause of pseudoflexion deformity. So somebody coming with pain in the left hip or unilateral hip pain with like some sort of a flexed attitude, we should not rule out a pseudoflexion deformity in the hip joint, because we have to make sure that clinically we see that the extension is passively possible. Unless it's a fixed flexion deformity or a pathology coming from the hip, these cases can also present with a pseudoflexion deformity, where passively when you extend these patients, they will have some extension. And that flexion is caused because of the sustained spasm of the iliopsoas. The other is the gluteal and hip region spread of the abscess, where they limit mainly the movement around the hip joint. So consider this patient. Now this patient, as you can see, this patient eventually had come with a lot of dental caries on the right side of his cheek. Okay, he underwent some interventions, and the oromaxillofacial people treated him. Then he comes with an ulcer which is non-healing on the left side. Now they sent biopsy, and now they started treating him for Madura mycosis, thinking that how can it manifest this thing? But what they forgot is that at initial presentation, there's a subtle torticollis, which eventually progressed further. And when we kind of saw his neck movements, they were very stiff, only so that we got a screening of the sagittal spine to see that he had a full-blown prevertebral and paravertebral collections in the spine, and almost a straightened out flat spine, where the abscess is percolating right from the C5 up to the D10 level. So this is how it has, and this was detected way early. So thankfully, he did not develop any deficit. But that's what I'm trying to say, that just because we feel that the location is unusual and we treat a certain kind of disease just by the telltale, we had to redo his biopsy, eventually to realize that the initial lesion at the mandible was also a manifestation of a full-blown Koch's, rather than him being treated for a Madura mycosis. So this is how, how variegated and how bizarre these presentations are. And as we speak and as we discuss this every day in our societies, we will only find more permutations and combinations as to how differently Koch still surprises us with its presentation. So coming to the most important one, which is the neurodeficit. So neurodeficit, mainly Koch will manifest as myelopathy, as radiculopathy, and as spinal cord syndromes. Now, essentially myelopathy, if there is compression which is more anterior, as Koch is most of the times an anterior disease, and if the compression is at the cord level, we will always have features of myelopathy or at least an upper motor neuron type of presentation. Radiculopathy can occur when Koch is mostly found either localized in the cervical spine, which is very rare because there is always some sort of a myelopathy component associated with it, or purely in the lumbar spine where you have features of instability associated with it. Now, the third and the most important presentation is the spinal cord syndromes. You may have a patient with, having an MRI with not so much of compression, and you see that one day in the wards, he may suddenly turn flaccid. That's because of the ischemia of that wet disease, which can happen where the presentation is classic of an anterior cord syndrome because of that anterior spinal artery ischemia. Along with that, we have our usual, the conus medullaris and the cauda equina syndromes based on the common pathology of Koch, which is at the thoracolumbar junction. So you can have a caudoconal type of lesion, and you can have a pure lumbar lesion presenting to you as cauda equina syndrome. The rarest is when the lesion, without disrupting any vertebral body, will present from behind the cord, which is like a spinal tumor syndrome, which is a very rare variant of it. I hope that is discussed in the presentations next based on the radiology. But apart from the classic paradiscal and the lesions which affect the body, there is a rare variant which affects only the posterior aspect of the spinal cord, which is presents to you as a spinal tumor syndrome. So these are the things which with how the patient may present to us. So as we know that Professor Tully had graded these based on, there was a classification depending on the clinical presentation of the patient, where the patient was unaware is grade 1 of its deficit. Grade 2 is where the patient is aware of the deficit but manages to walk with support. Grade 3 is moderate deficit, where the patient becomes non-ambulatory because of paralysis in extension. And grade 4 is severe deficit when there is paralysis of flexion. Theoretically speaking, this classification is good to memorize, but believe you me, it is not always how patients present to us. This is not a classic referral these days, because you will never realize how quickly the neurology progresses, and there are a lot of additional factors based on which this can happen. So to kind of further evaluate this, so Professor Anil Jain came up with a very nice paper in 2005, where he evaluated these systems of grading deficit in tuberculosis, only to conclude that neither the Tully grading nor the Asia alone can effectively grade all stages of neurodeficit in Koch spine clinically. The neurodeficit in tuberculosis of the spine should be described in stages, and each should have a sensory level and a motor level. This is a very vague classification according to him, and he said that a comprehensive classification which notes the sensory as well as the motor function should be incorporated into our practice. Then came a nice paper by the AIMS group from Uttarakhand, where they predicted neurodeficit in patients with spine tuberculosis, and they found cord edema, canal encroachment, and more than 50% significantly, they predicted better neurodeficit than most. So the conclusion here is, most classification systems, even today, cannot predict neurological deterioration only by clinical evaluation. It has to be a radiological or a clinico-radiological evaluation for us to understand that whether this will progress or not. So coming to the most important part of this, which is almost a hallmark of Koch as we know it, which is deformity. So deformity comes with kyphosis, kyphoscoliosis, and torticollis. So it can be like a knuckle. We are all aware of a knuckle, kyphus, and gibbus, but most of the Koch's spine present to you as a rounded kyphosis, which develops over time, most importantly seen in children. Why? Because of the flexibility and elasticity of their spine. Second is their head to trunk ratio. They have to support a very large head over a very narrow trunk in their initial days till they grow till 5. So the entire tendency of the spine is to kyphose. And thirdly, the disease progresses much faster because of the elasticity and the very weak, weak and the very developing kind of a spine. Consider this child. Now he presents to us something like with some sort of a truncal shift like this with a very bad torticollis. With, you can see like a very picture only when we evaluate him to know that at least 3 to 5 vertebral bodies in the cervicodorsal spine are missing. But he presents to us in a very very different manner where it is more like a higher tilt of the cervical spine with a shift to one side. So you don't know how these patients actually present because the pathology still lies way below. But look how he's presenting. This gives us a very, very confusing picture, if I may add. So coming to pediatric Koch's, these are the ones which you have to monitor, not from 1 year, 2 year, but you have to monitor them at least for 4 to 5 years, depending on what age group they present to you with. Active disease, wet disease, please, please, please have strong vigilance and surveillance over these children because you will never know when they progress. Unless the moment we find any of the 4 spine at risk signs, they are the first indication for us to kind of operate them and at least stabilize them before they go into some sort of a dense deficit where the surgery then becomes bigger. I mean, to identify these people, to splint them, and to ensure that they follow up with you regularly is the first thing. Because if they don't, then the growth spurt will occur. They think that the doctor has treated the disease only to realize that they will come with something like a long-term follow-up where you will see that both the bodies have united over time and he's gone at least into a 60-degree kyphosis after maturity. So this was the third picture in the bottom was when the child came at 14 years of age, where he was treated with Koch's conservatively elsewhere, only to come with some sort of a deficit later on. And I am just giving you a very, very common example that it is no longer said that Koch's will be only an anterior disease. You see the first picture to the top, where you see that there is not only some amount of sagittal kyphosis and coronally vertebral destruction, but if you see, the abscess extends even into the posterior column, even into the posterior ligamentous complex and in the muscle. So this is something which you see very rarely, but it is now increasing with time given the kind of resistance also we have, that they have become very aggressive, that they just don't stay and confined to one place. They are aggressively expanding and they are entering. They are no longer to be told as pure anterior lesions. That's what I meant. So this is one case which I wanted to show. I mean, I know the talk is on clinical presentation, but I will just show you that how it can actually demonstrate pure instability also. So now this patient comes to us to the casualty with this pain. He had transitional pain, which was pain more on sitting and on side turning. Okay, so this was the first X-ray which we did on weight bearing, where you can see a collapse of a L1 vertebra. Now we get the MRI done. Now this is the MRI. Although the sagittal cuts may still not be representative, over time, once you see the coronal and axial images, we see that there is paravertebral and some psoas extension of an abscess. But the point was not how he had done. This patient, over 3 months, has developed a conus medullaris syndrome because there was instability. And you can see why I was saying that it is because of the junctional kyphosis and the collapsibility of that collapse, the sponginess of that collapse. You see how it has completely collapsed on the sitting pre-op versus when we position him and when we just kind of restore the alignment, you see how it has opened up completely. So this is where even like a pseudo-arthrotic OVCF, Koch's can present with some sort of, with most features of instability, apart from the classical features of discitis. So this is basically my overview on the clinical presentation of Koch's. I'm open to questions, guys.
Thank you, Rohan. It is a very good presentation, and I think you talked about the various features which are clinical as well as the examination point, and also last but not most important is the clinical instability, where we may not have a static image showing a significant compression, but patient is not able to walk. There's one question from me, and then we'll take also other questions. Are there any clinical feature by which we can prognosticate the outcome, Dr. Rohan?
Clinical features by which we can prognosticate is
Yeah,
mostly,
for example, rapidity of deficit or the severity of deficit, or because there's a lot of equal papers which are talking about the both sides, as you
yeah.
highlight.
So I mean, we both know that, how, whenever these patients come to us, unless clinically I feel that there is a significant amount of pain. I mean, we'll first talk about an adult and then we go to the pediatric group. But in an adult where there is no clinical presence of pain, which is excruciating or which has progressed over a certain amount of months, and in the presence of Koch's, these are the ones where we can actually take a call that, the signs of instability are not there, and maybe despite of a mild kyphosis, we can still hold on to our conservative trial, which we had started after doing tissue diagnosis and putting him on AKT. So these are the ones which I would be very this thing. But somebody where you have a 3/5 and he's deteriorating, or we have something where you have a subtle myelopathy signs and then he becomes a non-walker over time despite of we doing a tissue diagnosis. These are the ones which we would kind of put them into our aggressively patient group where which mandate surgery over time. Yes.
So, Dheeraj, what is your view? Are there any features which you think which are like a patient coming with a bed sore and zero power for longer duration? How do you see clinical features in a current scenarios?
So you are talking about the outcome, regarding the outcome?
Yes.
Okay. So the worst feature is having a flaccid paralysis and for longer duration. So this is the worst feature. Next to that is spasticity. The spasticity is sometimes still I have some hope that there is something left there. Then after that there is some sensory power, especially the superficial touch and the motor, if at all is there. So that's the best thing which has the best chance for recovery. So that's how I go.
So,
Can I ask one question to
right.
Rohan?
Yeah.
Yes, sir.
Yeah, Rohan. So sometimes in my outpatient clinic, if these patients we have to pick up very early,
Yes.
uh, because they just present with some back pain, which we may find that it is non-specific, and we won't advise anything beyond the X-rays. And X-ray also doesn't give us much information. So how you decide to go further for MRI, or how you differentiate this patient for chronic back pain to tuberculosis?
So it is actually case to case basis, if we may add.
Right.
And
Hmm.
it is also about, I mean, gauging that what exactly is his back pain like. I mean, if
Hmm.
it is associated with stiffness, like if I find any element of something mimicking for a chronic period of time, mimicking something like an axial spondyloarthropathy, I will not hesitate to go for a serology along with the X-rays day one. Okay, so that is something which I've seen, and which I don't mind over investigating these people,
Hmm.
even CBC, ESR, CRP along with the X-rays, and
Okay.
for me the second threshold would be the MRI. But again, it is about in how much time is he coming to us, and what is the progression of his symptoms clinically from the first visit of his, if he comes back to us within 2 weeks or 3 weeks, which would force me to kind of go for an MRI immediately. But along with that, having these serological markers is not a bad call, because it will not cost him much, but it will at least arouse the suspicion that these are the kind of patients which I have to pick up and maybe kind of force them to get an MRI, because I might
Right.
just something which is not there.
Right, right. So so just to add to this, so there is something called as oblique views. So I have read about this, but I have not used it practically. Generally speaking, other of my panelists can add information to that. So there is something called as oblique view, and we should look at the anterolateral corner, and which is supposed to be the highly vascular area of this vertebrae. So these are early to be getting eroded, and that's how we can pick up on X-ray at least this thing. But I've never tried this oblique. I've just it came across my reading someday. Anybody who are applying or using some other modalities, I am not aware.
So I think now today in the era the MRI is so early. I think if there is a patient has a mechanical, not a mechanical, but infectious kind of a back pain, and if it's chronic, his personality, weight loss, we should have a very low threshold for ordering a good
Right,
because it's
right,
better to
Best
because
is to over investigate rather than miss out on that, you know.
because
right,
if we
right.
are in an endemic country, we should not be taking much chance. I think that's very important. Dheeraj is trying to highlight. We should identify those sets of patient which are going to be a kind of a infectious and not the mechanical back pain.
Right.
So
Any
we have a
question?
question where some Dr. Mitesh has asked, how much does CT guided aspiration of a psoas abscess help in conservative management? Any role of it, or is it just a diagnostic tool? I think
We're
that
gonna discuss that in a
discuss
part
this
of
here.
next
Yeah,
lecture. So we'll discuss. I think if there are no questions, we'll proceed for the next talk, Dheeraj.
yes.
Yes,
Thank you.
can.
Yeah. Thank you. So I'm going to discuss about the diagnosis part. Is my screen visible?
Yes, yes. Please on the play.
Yeah. So we already seen the clinical features. Now the diagnosis, because we know there are various ways that tuberculosis can mimic in a different form, and it's very important to have a proper diagnosis at our hand before we embark on any particular treatment. So we'll start with the example. For example, this is a 65-year-old female who presented to us with a severe back pain since 5 months. Again, as we just discussed, the patient had a gradual onset spastic paraparesis with a diminished sensation below umbilicus at the time of presentation, with both sphincters involved, and the patient was already on AKT since 2 months. That's another problem, that a lot of patients already take an empirical AKT and then they present to us. The MRI showed again an abscess formation, cord compression, paravertebral abscess. And now the question that comes to our mind is what to do next? What are the hematological tests we do? Because the patient is already on IKT, whether we need a CT scan as well, apart from X-ray and MRI. If we plan for a biopsy, whether we should do biopsy at the time of surgery itself, or we should do biopsy before and then do a surgery. Or if biopsy is planned, as somebody asked, should we do a CT-guided biopsy or a fluoroscopy? And what are the container, what are the sample tests one should order? And this is going to be precisely the aim of the talk, which we're going to cover, that these are the bare essential thing which we require. So coming for the imaging first, as we already discussed upon the X-ray, there are certain important points which one has to keep in mind on the X-ray. First thing, X-ray, they pick up the tuberculosis quite late because almost 1/3 of the bone has to get resorbed before we pick up these things on an X-ray. For example, here you can you can see that this patient has a loss of disc space around this area. So this X-ray changes occur quite late, and these changes usually have a rarefaction of the vertebral end plates. They will have a loss of disc height, osseous destruction. Sometimes you can see rarely a sequestrum also, which is very well seen on a CT and MRI, but not on X-ray. But sometimes if it's extensive form, you can see. And as you told, as we discussed, it's also important to understand how much is the vertebral body loss is occurring. So there's a good study conducted by Dr. Anil Jain, who showed almost a one vertebral body loss will give a kyphosis around 30 to 35°. This also depends on where is the lesion, whether it's in a lumbar spine, thoracolumbar, thoracic, or cervical. But this is an approximate estimate. Then you'll ask me, why do we need to know why this amount of kyphosis? Because we understood that the tuberculosis presentation, maybe the patient may present with you without any neurological deficit, but a significant vertebral height loss, which in turn in long term can cause a significant kyphosis and can present with a late onset paraplegia. That is another clinical presentation of tuberculosis which we can see, which is called as a late onset paraplegia. And it's very important to detect these patients early on. Dr. Rohan highlighted spine or trace sign in our kids. That is one of the reasons, because these kids are going to have a future, a very significant buckling collapse and relentless destruction and significant kyphosis in the latter part of life, and that can present as a challenge. So it's very important to detect these cases at this point of time and not just address those patients only who have a deficit. If your patient doesn't have deficit, doesn't mean that he doesn't need a surgical management, and a vice versa. A patient having a deficit may do very well with a conservative treatment, and we're going to discuss this in our conservative and surgical outcome. So the point on X-ray is that we need to know how much is the amount of bone loss. So usually 1.5 vertebral body loss causes something more than 50-degree kyphosis and can have a higher risk of causing a late onset paraplegia. For example, this young patient had completed the AKT and presented at a very late stage with a late onset paraparesis, significant mechanical back pain. You can understand the muscles are working in a reverse way. So it's a very energy consuming for the muscle. They go fatigue. You get also because of significant indentation and salient compression on the cord. These patients get a deficit as well and becomes a complete VCR surgery for these cases. Now coming to the MRI. So MRI is a very important investigation and one should have a lesser threshold to order it whenever you're suspecting a spondylodiscitis. What is the advantage? We all know that it gives you anatomical localization, early detection. It indicates how much is the extent of bony and soft tissue destruction. And most important is that we know in tuberculosis, we get a lot of times skip lesion, which patient may not complain of. That can be very well seen with the screening of the spine. So it's very important to order a complete screening of the spine when you are ordering a MRI in this patient. Again, there are various classical features like this subligamentous abscess formation. Also, you can see in an axial section, there are multi-septate collections. These usually have a peripheral rim enhancement. They have a both prevertebral and epidural component. So these are very classical features of tuberculosis. Once you see more and more MRI, you will be able to recognize it. And that is important part. And second point which I want to bring your attention is the interesting point is that nowadays we are seeing both kind of a Koch's. One is a wet, which is exudative Koch's, and sometimes we see something called a dry Koch's, where you will not see much of amount of exudative tuberculosis or large abscess formation. What you can see just a granulation tissue, but you can see the cord signal changes, and these patients may have a very severe static deficit, so or a progressive deficit. So this is another component which we'll have a discussion in your case presentation as so. So there are various features on MRI which, as a treating clinician, one should determine and not just depend on the MRI report. Now, third point is a CT scan. So what is the significance of CT scan? We all know now that we have a multiple reconstruction and tuberculosis because these patients take AKT. Sometimes they are defaulter, they have taken AKT and then they stop the AKT. So these patients may have a vertebral body destruction, but also a pedicle destruction. For example, this young kid, she had a significant pedicle destruction. And if you're going to address this wet Koch's and do anterior-column reconstruction, it's very important to have a good pedicle anchorage. But if your pedicles are destroyed, then it becomes very difficult, and then you have to have a different way of instrumenting the cases. So it's very important to understand the morphology and the CT scan before you embark on any treatment. So that is where the CT important lies. And this is how the multiple reconstruction will show you whether the pedicles are sclerotic or they are absent or they're destroyed. And if one just goes that I will just do a pedicle screw, one can land in a significant trouble, because in a tuberculosis, you don't get an anterior hold. It's not easy to pass a pedicle screws in an already destroyed body. So one has to have a proper understanding of the imaging to before you embark on especially a larger deformity. Regarding the before going on a biopsy, hematological investigation, most important is we always order a basic hemogram where we get to know what is the nutritional status, hemoglobin status. We also order the CRP and ESR because these are going to be marker for you to subsequently follow up the patient, and we are going to see the improvement, and we do see the improvement with respect to ESR and CRP. Third thing is it's very important to order LFT and basic RFT because LFT, we all know the most of the anti-tuberculosis treatment is hepatotoxic. We want to know what is the baseline SGOT, SGPT, and also the new second line and other drugs can have also other issues with RFT, also the ECG. So these are basic investigation which we should do. A lot of people like to involve ID specialists, but I agree a lot of people may not have access to ID, especially in a tier 2, tier 3 city. So these are the basic investigation which we do. In KM, we usually prescribe the AKT drug sensitive AKT by ourselves, and MDR and XDR, we refer it to the chest TB. But it's important if you have a facility of chest TB, it's better to involve them, and that we're going to discuss in a conservative management. Regarding the biopsy, now we have two options, the CT and the fluoroscopy. Before going on the CT and fluoroscopy, if there's an obvious abscess, which Dr. Rohan described, if it's in a petit triangle, or if it's in a psoas area, or if it's very accessible in a dorsal area, then one can straight away go for aspiration and send that sample. It has a both therapeutic and a diagnostic work. The abscess drainage does give a symptomatic relief to the patient. So whenever it's possible, try to aspirate as much as you can aspirate. And second is that the diagnostic yield becomes much higher. Now, there's always a question whether we should do CT and fluoroscopy, and this is we're going to discuss in subsequent slides. It's important that the specimen should be sent in a sterile Falcon tubes. Usually, your specimen should be reaching the lab within 6 hours. If it's not reaching within 6 hours, it's important to refrigerate it, but don't freeze it. Second, all the samples should be sent in a sterile container without any preservative like a formalin. Formalin is for histopathology. So please don't mix your sample with a formalin when you are sending it for a microbiological diagnosis. If your tap is very dry and if you are not finding anything, or if you have minimal tissue, you can add a saline into it to just get it in a moist manner. Any sample which is more than 3 days old, please discard it. It's not going to be a relevant. And try to avoid mixing of blood sample because this can interfere with the gene expert test. Now regarding the fluoroscopy, which a lot of orthopedic surgeon as a we know how to pass a pedicle screw. So it's similar to that. The procedure is, but it's very important to target a particular pedicle. By fluoroscopy, you can access more than 50% of the vertebral body, and it's amenable for biopsy. So fluoroscopy has an important say. Procedure per se is not difficult. Usually we do it under local anesthesia and intravenous sedation. You get a real-time monitoring because patient is responsive to your treatment. So it's important to keep talking to him, see for the deficit. The duration of the procedure itself is a very short. If you accurately cannulate the pedicle, your sample yield will be much better, and it avoids the complication with the paraspinal needle, which go through the foramen or which can violate the chest cavity. This procedure is inexpensive. The only drawback of this particular fluoroscope is inability to visualize the soft tissue. So if you are going in the foramen area by mistake, then there's a very high chance of causing a hematoma formation. Sometimes you get a false negative result because you are not tapped in a proper way. There could be a nerve root injury if you breach the inferior pedicle wall. In a thoracic spine, you may, if you are not careful, you may injure a spinal cord, or if you needle goes too laterally, you may cause a pneumothorax. So one has to keep in mind. Now the CT scan, the advantage is, for example, if you have a lesion like this, it becomes very easy to target this area with a CT scan because you are getting an actual imaging support, which you don't get with the fluoroscopy. It is precise for a smaller lesion. But again, the radiology being doing that particular procedure, so sterility, procedure length, and the amount of ionizing radiation to both patient as well as the treating physician is a concern. So there have been a lot of studies. The concern is what is the size of the trephine should be. So the paper which talked about 2 mm trephine being sufficient. There are some which talked about 3 mm. We're going to see the diameter of the needle. But if you see overall consensus, the accuracy rate, operative time, complication, and pain score of both fluoroscopy and CT are equal. But the radiation dose which is given in the CT is much more. If you talk in general among the treating orthopedics or spine surgeon, you will see that the yield, usually the tissue yield of the fluoroscopy is much higher than the CT guided, but it depends, and it's a individual. It's like a person who's doing it depends on a lot of things. So which pedicle, the expertise level, where exactly it's being tapped. So usually we should not be rigid that we'll only go on a right side or we'll go on a left side. It should be done as per the nature of the lesion, and you should target more on the peripheral part. Now, previously we used to have a Jamshidi needle which had a radio opaque handle, but now we have a green plastic which is radiolucent, so it becomes very easy to see end-on visualization. What is this? Is the Koch's needle, which is commonly used by the radiologist. If you see, the diameter is 13G, whereas the one which we commonly use for a fluoroscopy is a 11G. So probably that is another reason why we get a better tissue yield with this particular kind of needles. Now, we all know that tuberculosis is a medical disease and treatment. So another rare presentation is very common in this kind of cases. So you can see the abscess like this. This patient presented to us in a casualty. Registrar told me that he has probably an assault injury. He had a history of assault and he had a huge abscess formation. When we did a MRI, we saw large prevertebral abscesses as well, and which was draining because of assault. He had a refracture and whole abscess which was sitting in the front part got completely drained on the back side. So sometimes it could have a rare presentation, and then we aspirated it and it eventually healed very nicely. So it can mimic. Now regarding the investigation, there's always a question that what are the investigation one has to order. So the main three investigation that we want to know is what is a microbiological diagnosis, which we do by smear, culture, and sensitivity test, because we want to know what are the antibiotic. And second, we want to know what is the histopathological examination. And this drug sensitivity test, which we discuss, can be of two types. Either you grow the organism and then check the antibiotic on them, which is called culture based, or a molecular based, which will be like a line probe assay, which we do. So the common tests which we order are the routine gram staining, culture, anaerobic culture. When you are suspecting that, it's not easy to send anaerobic culture. You have a specific container for that. The AFB staining and LJ culture and fungal culture should always be done whenever you are suspecting, especially the fungal in the is a differential. Now we have a TB immediate way of understanding, which gives a faster result. And conventional, the gene expert is giving you much, it's been a game changer. It gives you a result much faster with a higher sensitivity. And no sample is complete without sending a histopathological, because you may have a tuberculosis being confused with a tuberculosis may be confused with various other sinister pathologies. So it's very important to send a histopathology along with the microbiological diagnosis to understand what is the disease process which you are looking at. Now coming to this rapid molecular test, and these are mainly the line probe assays and nucleic acid amplification test. And I want you to be aware, because this is going to be the future diagnosis where the tuberculosis is going towards. Both are line probe assay and the NAT test, the nucleic acid amplification test, are both are PCR based. What is line probe assay? It gives you information for you can do a antibiotic resistance for both first line and second line. AKT drugs can be understood by the line probe assay, and usually results are available within 1 to 3 days. Whereas this NAT test, the cartridge based test, which is gene expert, which we commonly do, and now the national program is incorporating this Goa based true NAT assay, which is chip based. What they do is they essentially detect the Mycobacterium tuberculosis 1, and second, they also detect the rifampicin resistance only, no other resistance, only rifampicin resistance. And the result, if you see, they are available very quickly. So CBNAT gives you results within 2 hours, that is gene expert, and TrueNAT will give you results within 1 hour. So that is a very fast transition time or the workaround time. Now there is something called as a Gene Expert Ultra, which is being commonly utilized, because what we see, especially nowadays, we are seeing trend, because these patients are already on AKT, is we see a possibacillary tuberculosis. So the conventional Gene Expert detects approximately 131 bacilli per ml. You have to detect it. Whereas Gene Expert Ultra can detect almost 16 bacilli per ml. So it's very useful in a possibacillary, where especially kids are involved. There are other tests like a pyrosequencing, which is also there, but it's expensive, and there are various limited centers and not being commonly done in India. Line probe assay is basically, if there are multiple probes which design and which detects basically a antibiotic resistance which has been conferred to a particular organism by a mutation. So these assays are targeting to that particular nucleic acid sequence. So the dictum is, for your easier understanding, is that whenever we have done a gene expert test and we got an organism which is rifampicin sensitive, then you will order only first line probe assay test. You want to know, because you already know that rifampicin is sensitive. You want to know whether your other first line AKT is sensitive or not. So even if your rifampicin is sensitive, you will order a first line LPA. And this is the National Tuberculosis Program guideline. If you do a gene expert test and your rifampicin is found to be resistance, then you have to order both first line LPA and second line LPA. If you talk to chest TB physician, they'll always say, because your patient has a rifampicin resistance, he has a very high chance of being isoniazid resistant as well. So it's very important, but it's not vice versa, which is applicable. You may have isoniazid monodrug resistance and not the or may have a polydrug resistance. So it's not a vice versa, but R resistance usually confers a I resistance as well. So when you have a H or the rifampicin resistance, which is there on a gene expert, always order both first line LPA and second line LPA to understand the drug sensitivity pattern. And what is interesting is that the results are nowadays available within 48 to 72 hours. So you can technically start a MDR regimen as early as 48 to 72 hours. And this is another advantage of the national program. Now, we already discussed, these are the tests, but we also have a phenotypic and the proper bacterial culture test. So the conventional culture media, which we learn in our MBS, the Dorset, the Thashi, the Loefflers and Middlebrook. But now we have a radioisometric culture media like a Bactec or Bactec Migic, which has a Mycobacterium growth indicator tube assay, which gives a fast result. So if you see a working time, the solid LJ media used to give us a result of antibiotic sensitivity within 3 to 8 weeks. Now liquid culture can give it as early as 8 days to 2 weeks. The line probe assay, which I just described, 48 to 72 hours. The gene expert and TrueNAT gives you assay result within 2 to 1 hour. So it's a pretty fast workaround time, which has made a diagnosis of tuberculosis much better. And again, always be very suspicious of drug resistance pattern when you have kids like this, which are children's, where we see a lot of time drug resistance. This child has almost lost 8 vertebrae body, or the patients who already started on a previous anti-tuberculosis treatment, or a typical presentation, multifocal disease, or immunocompromised and coming from endemic area. So if you see National Tuberculosis Program, there's a whole category called as a presumptive AKT. where you're already given AKT and patient is still not improving, or if you are done completed the treatment again presenting with the new lesions, or you are not getting a bacteria in spite of doing a biopsy, that is a time when you can consider this presumptive and can start the tuberculosis. So it's not that you will always get a microbiological diagnosis. This kid we operated from a posterior side instrumented and then he went on recovering. So if you see, the tuberculosis is the whole spectrum, and there are various tests which one has to keep in mind. It's very important for a treating physician to understand what are the battery of tests which is available and use them judiciously. Don't order TB Gold Ferron and base your treatment on those. Immunological tests have very less relevance nowadays, and that has to be kept in mind. Thank you.
Great presentation, Tushar. Tushar, so to summarize, what are the four things which we have to do while doing biopsy, and what are the common errors which common orthopod do?
So the common error which I see is that the people think that the patient is already started on a tuberculosis, I will not do biopsy. No,
Okay.
you have to do a biopsy in any other case. Even if a biopsy is done previously, not done, you have to do it, and always try to find the organism. Because we learn shortly, Dr. Shiti is going to present the medical, the conservative treatment. Tuberculosis is a medical disease and we need to find. Now we have an advent of tests like Lyme probe assay, which can even detect the dead organism. So the biopsy has to be done. Second, the sample which you are obtaining. So I'm a more of a fan of fluoroscopy guided. We feel
Same.
that the tissue yield is much better, and I think the panel will agree with me. But it's not necessary. Some people have advent of CT and they get a better yield, so one can order CT. Whatever works in your hand, you should order it. So fluoroscopy, proper targeting of the lesions, always sending the sample for both the NAT test, which I already told you, Lyme probe assay, the culture, and also the histopathology. That is another fourth important thing. Transporting the sample in a proper medium and with a proper preservative is also important. That is also important. And don't freeze the sample. You can refrigerate, but don't freeze them. So these are the
Right.
basics which I feel should be always considered in the mind.
Right. Any other questions from our panelists? So there was a needle by Dr. Dave. He has devised one needle of I think 5 mm thickness with a disc-like instrument passing through that. Through that, with the chances of getting a high in biopsies has been what he has been proving and pushing on.
So if you see literature, there are usually 2 mm, 3 mm are found to be sufficient. So I think 3 mm is more than enough. 11G needle give you good issue. If you're not getting it, you can target at a multiple sites. I
Right.
don't think 5 mm will be too broad, but these are the one which commonly done.
Right.
So,
Yeah. What?
Dr. Dave's paper was, I think, published back in 2007 or 8. So, based on the same thing, we just kind of re-sterilized the kyphoplastic cannula that we had from Medtronic. So that kyphoplastic cannula is wide enough that even a pituitary ronger can go through it. Now, this becomes important when you have the drill guide that comes with the cannula. It is important in those lesions where the disease has become much more sclerotic, like you will not have a wet component, so then sample adequacy becomes an issue. So that is the time where you can use this wider bore and get a better, diagnostic accuracy, because sample adequacy is something which I feel that whenever you go for a CT guided biopsy is something that we really struggle with, because we have still not reached that era where we can literally differentiate, okay, you know what, this is an out and out wet lesion, this mandates a CT guided biopsy where they are better than us, or a lesion where you don't have that much of a wet component and a transpedicular or even a transforaminal or a cambian access can give us a better yield and not repeat the procedure. So I think that discretion can be made by us spine surgeons, and even I think that we can use a bigger bore and get a better sample.
The next talk is going to be already by Dr. Kshitij, but I would like to ask him in advance that now we are seeing talk about the cambion. What is the role of this endoscopic debridement versus diagnostic that a lot of people are doing, where the lesions can be managed conservatively also? So
I think it's a good idea. I mean, endoscopic debridement, especially for pyogenic discitis, I'm not certain for tuberculosis in general, because like my talk is most of the tuberculosis is conservatively treated. And the ones that don't need conservative treatment, that need operative treatment, are probably not the ones for endoscopic surgery anyway. But endoscopic debridement is probably would be good for, let's say, pyogenic discitis in the pre-destructive phase. So when discitis happens, you don't have a lot of bone loss. It is just within the disc. There is no like spondylolisthesis or destruction happening. So pre-destructive phase discitis. Um, uh, so disc debridement endoscopically, not only you'll get a good sample, but you'll debride the disc as well. So I think that is a very good idea. And those people who can do it, they can put two cannulas from both sides and wash the disc out. Doesn't work for destructive phase. The ones who have
Right.
instability pain and on, usme, if you do it, the patient is going to howl in pain even after doing all this. So there
Right.
is surgical fusion, but yes, early stages possibly it's a good idea. I mean, endoscopic biopsies also are not a bad idea in tuberculosis for those who can, get it.
Mm-hmm.
But having said that, I mean, as you said, it depends from center to center. We have good radiologists who can do CT guided biopsy. We have never done a fluoroscopic guided biopsy since the time I have been in either HN or Hinduja. So the guys who do CT guided biopsy do much better job. What we tell them is that you have to take at least 6 course.
Right. So actually, there are some
There they
issues
will
with the
not.
public hospitals.
So
The
there, that's
size
a
of the
problem.
needles is fixed. Sometimes the sample remains there for longer time, and then through the procedure, if it goes to the right place, it takes time.
That is
The
absolutely
junior most,
true.
the junior most person must be doing that, and he may not
I
be
agree.
targeting the right point. So all these things are
I
the
agree.
issues in the
I,
public hospitals, and it takes longer time. So none of the consultants are keen to do this.
Dr.
So
correct,
Dr. Nene
correct.
is
yes,
there.
I think
What is his view about the endoscopic debridement and sir, the CT versus fluoroscopy?
So I'm a CT guided biopsy fan, and we always send because it becomes a no-brainer. It gets off your list. It takes a lot of time of the system gets saved.
right,
And as far as
right.
endoscopic debridement goes, I think it's an overkill for TB because, like Kshitij says, either surgery or no surgery. Then why do you want to do endoscopy when you can do it through a needle? And if it's surgery, then you just go ahead and do the whole surgery.
Right, right. One question is for all the panelists. So there are sometimes we also have this tricky scenario. We always are all of us are propaganda for doing biopsy before starting AKT in all the patient. But there are some areas like cervical spine, which the radiologists also are not keen to do biopsies, and we also as an orthopod can't do the biopsies through fluoroscopy. And so what's the way out? Or then to start empirical AKT and or what's the other way?
I think
I
In
was
sir,
going
early
to show the
tuberculosis.
flowchart in the talk. So
yeah, he's covering
just
it.
the way of thinking, I'll show a flowchart of.
Okay, okay. Thank you very much. Thank you.
So I will invite Dr. Kshitij Chaudhary, who is a consultant at Hinduja Hospital, to take his talk through conservative management in a spinal process.
So can you see the screen?
Yeah, we can see your
So
screen.
I'll just tell a flowchart of conservative treatment. So obviously, most of tuberculosis is a medical disease, so it will be managed conservatively. And nowadays, we'll pick up spinal TB before complications set in because MRI is so readily available, and you have enough high degree suspicion. You get a diagnosis on MRI, and then you get a CT guided biopsy. So now CT guided biopsy, just to revise what was discussed in the previous talk. So you have two situations, CT guided biopsy not possible or possible. You can replace this for fluoroscopic guided biopsy as well. When CT guided biopsy is not possible, that is either it is inaccessible area or it is a too early lesion. Like, sometimes you pick up lesions on MRI that don't have like a well-defined abscess, or you just see edema in the bone. So it's a very early lesion to biopsy, or it is craniovertebral or some place like that where, radiologists also are not very keen on putting in a needle. So in those situations, inaccessible situations, you don't really have a choice. You're starting empiric treatment and then seeing the treatment response. And obviously, empiric treatment is started by the infectious disease consultant. There is a different way of keeping a follow-up on patients who you treat empirically. Early lesions, sometimes we do get an interval MRI, sort of wait for 4 to 6 weeks, get an MRI again. Many times the disease sort of slightly increases and your biopsy yield is much better at that time. And then you can start on TB treatment, because these early lesions are sometimes difficult to identify as infectious as well. So you kind of can do a step and wait for a second MRI and then do it. Now, when you do a CT guided biopsy, there are the three possible outcomes of a CT guided biopsy. First outcome, very good outcome, is you get a culture. It proves that it is MTB, and you have a culture directed or a drug sensitivity directed AKT that is given to the patient. The best case scenario which we can have. The second scenario is histopathology shows a granuloma, but culture is negative. And this is not a very uncommon situation. So having a granuloma doesn't prove that it is MTB, because we know that there are other organisms also that can cause granulomas. So this is just a presumptive evidence of tuberculosis. It also means that the CT guided biopsy, the sample was representative. It took it from a representative area, but the culture did not grow. And the third situation is where your histopathology is also unclear. It shows normal bone and your culture is negative. Then you want to kind of think yourself whether this biopsy is reliable or whether the lab was reliable. Did they take a representative sample or not if your histopathology shows normal bone? If you feel that it is an unreliable biopsy, then obviously repeat the biopsy. But if the biopsy person is reliable and you are confident, and it all depends on the situation, then you have to make a risk assessment. So you make a risk assessment about the possibility of the patient being a drug resistant tuberculosis. And there are several things, we'll come to it, about clinical features of or radiological features that suggest that this could be drug resistant tuberculosis. And accordingly, you decide whether you want to treat this by empiric AKT, or you want to repeat biopsy, or even surgical biopsy for that matter. If you are very strongly suspecting that things are not going in your way, then you can do a surgical biopsy. But essentially, non-operative treatment, in my mind, what I'm thinking of first is how is the neurology. Two situations. One is normal neurology, or the patient has a neurological deficit. If the patient has a normal neurology, then you are looking at how bad the column is destroyed. If the column is destroyed severely, that means more than 2 bodies in the thoracic spine or more than 1 body in the lumbar spine, more than 40-degree kyphosis, circumferential damage in addition, and then there is progressive kyphosis on serial follow-up. Every time you are taking X-rays, you see the column is bending. So then those patients are better off with surgery. If the column destruction is mild to moderate, kyphosis is less, there is less than a body loss, then basically you are keeping a close watch, doing conservative treatment and keeping an observation for deformity progression. Now, if you have a neurological deficits, then neurological deficit can be a mild deficit, essentially a functional deficit. Patient is able to walk, slight problem is there, mild weakness, or severe deficit, that means non-functional power, patient is bedridden. So in general, patients who have non-functional power, who are bedridden, are in this modern era is surgery. If they have mild deficits, then it depends. The mild deficit can be because of a hard lesion or a soft lesion. Like for example, hard lesions are these kind of lesions where you have a bone sequestration or a disc retropulsion that is causing spinal cord compression, or the column is translated and causing spinal cord compression, or there is an internal gibbus that is bony that is causing spinal cord compression. And what I mean by hard lesions is that no matter how much ever antibiotic you give this patient, the compression is not going to go because the compression is bony. And in those situations, you are looking at surgery. So if you have an abscess for a compression or a granulation tissue for compression, and if you have a mild deficit and the patient is walking, then you can choose conservative treatment for those patients as well. So coming to the mainstay of conservative treatment obviously is AKT or anti-tuberculous chemotherapy. But before we talk about AKT, you need to understand how this organism behaves, the Mycobacterium tuberculosis. This Mycobacterium tuberculosis is a strict aerobe. In the lung, it causes a multibacillary tuberculosis, but in the skeletal area, in the spine, it is a paucibacillary TB. So it is much harder to isolate this organism and grow. It is also harder to kill this organism because it is very slow growing. The replication rate is about 18 to 20 hours, one division. So obviously the antibiotics work when the bacteria is dividing. And if it is going to divide only once in 24 hours, it is much harder to kill. And in addition to that, the chances of resistance in this bacteria to antibiotics is very high, and that resistance can be primary or that resistance can be acquired. The frequency of resistance for INH is 10 to the power of 6, which means 1 in a million bacteria for INH will be drug resistance. And for rifampicin, it is 1 raised to the power 8. And if you give both drugs together, then the chances of selecting a resistant bacteria is 10 to raised to the power of 14. So always remember that bacteria will have some degree of resistance no matter what to these antibiotics. And the mycobacterial cell wall basically is unique. It has these lipids mixed with these peptidoglycan molecules which have very low permeability to the antibiotics. So you have to remember that. And they have these special molecules in the cell wall that allow for the bacteria MTB to live within the macrophage. And within the macrophage, the antibiotic doesn't reach. Any usual antibiotic does not reach. And that's why this whole idea or the concept behind giving multi-drug treatment for MTB, you are giving different antibiotics for different populations of bacteria that are multiplying in the bone. So the extracellular rapidly dividing bacteria are best killed with INH. The extracellular slowly dividing bacteria are killed by rifampicin. The intracellular intermittently dividing bacteria, that means the ones that are in the macrophages where antibiotics don't reach, is pyrazinamide. And obviously dormant bacilli, nothing will work, right? So that's the whole idea why multi-drug treatment is mandatory for tuberculosis. And we are giving that in 2 phases, intensive phase and the continuation phase. In the intensive phase, 4 drugs, HRZE daily for 2 months. And obviously no streptomycin, that we all know. And the continuation phase is HRE daily for 7 to 10 months. Why not HR? Because primary resistance, not distance, resistance to INH is 16%, right? So because of that, another drug is necessary, ethambutol is necessary during the continuation phase. It can be HR only if you have a reliable drug sensitivity testing that shows both rifampicin and INH to be sensitive. Then only you can give HR in the continuation phase. If you don't have that information, then it is HRE for 7 to 10 months. Obviously, it is daily treatment. That DOTS was a mess. So that is all gone for a toss. Now it is a daily regimen. And the doses are decided by the weight. Even the government decides the doses by weight. So there is no reason for orthopedic surgeons to write AKT4 and AKT3 on their prescriptions. So be careful. The government dosing is like this. This is the daily regimen. It's called FDC, fixed drug. What is F? Fixed drug combination. Like that sort of short form is there. But you can see according to the weight category, you have to decide whether you are going to give the patient 2 tablets, 3 tablets, 4 tablets, or 5 tablets. So it has become very easy. This is how AKT is given by government. And we also, if we are prescribing, then it has to be done this way. Right? So it is weight based. And I would say best is to find a colleague, a chest physician or an infectious disease colleague. And if you are practicing in Mumbai, you will find a lot of them and take their help for deciding the AKT treatment. The duration of treatment is controversial. We at present are giving about 9 months, but it is individualized. For some patients, it can extend to 12 months, and it's very rare for somebody to take antibiotics for 18 months. We do periodic evaluation. At the first 7 to 10 days, we repeat the LFT to monitor for hepatotoxicity. Obviously, you have done baseline LFTs. So after 7 to 10 days of AKT, you monitor your LFT. Monthly, you are keeping a follow-up in the intensive phase, doing CBC, ESR, LFT, uric acid. And then we get X-rays done every monthly, at least in the first month and first 2 to 3 months. Because remember, when the tuberculosis is wet, the progression of the kyphosis is going to happen rapidly only in the first few months. After that, it is going to slow down. So you need to look at the column more closely in the initial few months than later. And in the continuation phase, we kind of keep a watch on the patient every 2 to 3 monthly until the end of treatment. Response to the treatment. Now, if the patient is responding clinically, radiographically, things look good, we'll just continue the follow-up as is. If clinically there is no change, approximately at 3 to 4 months, we might repeat the MRI. If we didn't have any culture diagnosis on biopsy, if the treatment was empiric to begin with, and patient has not shown reasonable response to the treatment, by 3rd month or 4th month, we are repeating the MRI. But if the patient is getting worse on correct doses, patient is compliant, then and taking correct doses, then what we do is basically check therapeutic drug levels. Therapeutic drug levels are checked for INH and rifampicin like this. These levels are done at Hinduja, and and accordingly the doses are modified, because we have found that even for patients taking appropriate weight, INH and rifampicin, sometimes the therapeutic drug levels are not reached for these antibiotics, and then the ID changes these doses accordingly. Sometimes the reason for this worsening is paradoxical reaction, so steroids are added. You also have to think about development of secondary resistance. So you might have to repeat a biopsy or do surgery. The reason for worsening could be mechanical instability or pain that will be visible on your X-rays or bending X-rays or lying versus standing X-rays. And last is obviously a doubtful diagnosis. If your biopsy was inconclusive, if things are not going your way, you can't find a cause, the patient is worsening, then you can do surgery just because patient, you don't know what the diagnosis is. You have done repeated biopsies and don't have an answer. So that is kind of the follow-up that you would do for a patient. And while the patient is in follow-up, obviously you are looking at the patient's nutrition. You may give a brace depending on the situation for pain or for support. Especially for cervical spine, we use Miami J collars. Pain management in the intensive phase can be narcotics, Buvelar patches, tramadol, etc. In the continuation phase, we expect the pain medicines to reduce significantly. Physical therapy for patients who are, bedridden, early mobilization out of bed, walking, muscle strengthening, so that they don't become deconditioned. So physiotherapy is for that. So coming to drug resistance, you need to know MDR, which is resistance to INH and rifampicin. The incidence is quite high in Mumbai. XDR also, it's increasing. MDR plus any fluorocolone plus an injectable second line drug is XDR. And these are the risk factors for MDR. So if you have a patient who has taken previous AKT, if the patient is non-compliant, is a defaulter, immunocompromised, has an atypical presentation, children living in endemic areas where the drug resistance rate is very high, all these kind of patients are tricky to start on empiric treatment. So you have to be careful and then take help from infectious disease to decide what kind of antibiotic the patient needs. In general, obviously orthopedic people are not going to start MDR drug regimens, but you should be smart enough to identify a bad treatment protocol given by somebody else. So the principles are it has to be culture directed antibiotics. You cannot add a single drug to what is failing. Minimum 4 drugs that have not been used before have to be used. Toxic drugs will require monitoring. There is an injectable aminoglycoside in this treatment program for at least 2 months. The treatment is very long, 1.5 to 2 years, and this needs an ID consultant. So if you feel is not following this correct thing, you need to ask the patient to change the doctor and find somebody who is sensible, who will give the right kind of treatment. So this is just an overview of how we think about non-operative treatment. Most patients we would be treating this way. So I'll stop here and then we can take questions.
I think it's a pretty well covered in the terms of the conservative management of tuberculosis. Kshitij, I would also like you to explain what do you mean by paradoxical reaction, and when do we expect that, and how do we differentiate from disease progression?
So paradoxical reaction means when when in the intensive phase you are giving antibiotics and these bacilli are dying, the body incites an inflammatory or immune response to these dying bacilli, and that inflammatory response can cause more destruction and more pain, more increase or worse appearing lesions on the MRI. This usually in the first 2 or 3 months. Not rarely that it is there in the continuation phase. But having said that, we have a few patients where the ID have diagnosed paradoxical reactions much later in the course of treatment. But when there is a paradoxical reaction or worsening of lesions on the MRI and clinical worsening, paradoxical reaction is not the first thing that comes to your mind, because then you would be missing out on, patients who are not responders, drug resistance, and all that sort of a thing. So we end up doing repeat biopsies for patients who are clinically worsening as well as radiologically worsening. And if the biopsy shows the same thing, that it is sensitive and things are still fine, then maybe paradoxical reaction diagnosis is made and steroids are added. If the biopsy is negative, we don't have an answer. Initially, biopsy was positive. Later, biopsy comes negative. Patient is still worsening, but you don't feel that it is drug resistance. Then the ID definitely adds steroids and sees the response and then takes a call. But never is MDR started on the suspicion that this could be drug resistance without having a microbiological diagnosis.
I think Dheeraj has raised the hand, but before that, usually I think the paradoxical, they fare well and then they suddenly show deterioration, whereas the one who are non-responder, they have a kind of a continuation, kind of a decline protocol. And nowadays, a lot of people, I think they're using NSAIDs and then landing on a steroid. So they, like you said, immunological reaction, they usually respond to anti-inflammatory protocols as well.
It's a real weird thing. I have had a patient paradoxical reaction 1 year after treatment, which is very
they say 3 to 4 months, but yes, it can be.
yes.
And Dheeraj, your question.
Right. So many times we all have this question. These patients sometimes may not be responding for 4 months, 6 months, maybe 9 months. So when we decide for a rebiopsy or when we consider this patient to be a resistant patient, so is there any gray zone or any particular definition to define as MDR or not responders, something like that?
So basically, it depends also on the column. Non-responders, like if your column is reasonably stable and things are fine from mechanical perspective and your lesions are appearing more on the MRI, because there is no reason for you to have a new vertebra involvement, abscess that has come up in a different area. So multi-site, your progression of disease on the MRI is not what is expected in the intensive phase of treatment. You don't want new lesions to appear. The same lesion might look worse, which is very common. The same lesion looks worse in the next 3 to 4 months, but you having new lesions are a very kind of a red flag, especially after 3 to 4 months. most tuberculosis patients will show at least a clinical response, if not for any mechanical issue, in 3 months' time. So after that, you have increasing pain, new lesions on MRI is kind of not typical. Either your original diagnosis is not tuberculosis, or this is drug-resistant tuberculosis.
Other question which I would like to pose to Shikhi as well as the other panelists is how frequently do you do MRI when you are treating conservatively, or is it always a patient-based, like individualized treatment?
It is individualized for me. If I have like a definitive diagnosis, culture diagnosis is there, your patient is taking right antibiotics, patient is clinically responding, X-ray looks good, no MRIs. But like say patient has patient is empiric AKT, we don't have a real diagnosis, patient has been there and you are kind of patient is grumbling and all, then we'll keep a watch using imaging as well, in addition to the clinical features. But the more uncertain we are, then the more likely that we'll repeat MRIs.
Right.
So any standard patient who is responding, how many MRI usually on an average, like in a 9 months period, which you give AKT 9 to 10 months?
There's no fixed thing. It goes by clinical suspicion.
And X-rays?
X-rays are every monthly in the first 2 to 3 months and every 3 monthly in the continuation phase. Again, it would depend on the column, but on a general basis, it will be more frequent in the intensive phase and it will be 2 to 3 monthly in the continuation phase.
Abhay sir, how frequently MRI when you are treating conservatively?
So I think an MRI at the beginning of treatment and at the end of treatment is a must in my book, and I'd like to do it once in between at least, because we are in a referral center. We tend to end up seeing a lot of TBs. We made a pattern of doing, and our patients are being in a private setup, affording, I'm going to say, we do an MRI every 3 months. But I don't suggest that that should be the protocol for everyone. But I think beginning of treatment, end of treatment for sure.
And
Right.
you have come with a very landmark paper with respect to the duration of AKT. So
6
now
months and 12 months.
has it now you fixed it like us and how is your treatment with respect to conservative treatment? Though your talk is on a surgical, but what is this thing?
Like just in terms of duration, it's between 6 and 12 months because our paper could conclude that more than 12 months is not needed. So I think we all can very safely shout out from rooftops and tell the neurosurgeon colleagues that they don't have to give AKT for longer than 12 months for TB spine. But I don't think we can conclude that 6 months is the standard for all. So I think it's case to case basis between 6 and 12 months is I think what I can give out here.
And Dr. Shikhi, what is your endpoint of stopping AKT? What is your endpoint?
So the 3 endpoints I follow in order of priority is clinical improvement, radiological improvement, and laboratory improvement. So if clinically the patient is overwhelmingly fine, even if the MRI shows, because the MRI, as you all know, is oversensitive. So I would downplay the MRI, but vice versa. If the MRI looks okay, but the patient is just not doing well, you would want to hang your hat on the former. But as you know, there's no hard endpoint, and I like to stick my head out here and bring out a controversy which is happening in the north, use of PET scan to determine end of disease. And I think that's a completely wrong move. Like people are just moving the wrong way. PET scan identifies inflammation and does not identify, it identifies metabolic activity, not disease activity. So metabolic activity can remain for much longer after the disease activity. So you can't call, and plus it's not sensitive for TB compared to malignancy. So I think that's a very wrong shift.
I would like to slightly beg to differ on this particular protocol, sir. We are also looking at the role of PET scan. So what you rightly pointed out, the healing activity can be confused with the disease activity. So they do SUV max, but then we have a standard like a liver metabolism, which is compared and which shows a SUV max value in the range of healing activity. So they differentiate the disease pathology, the SUV max value ranges differently. So now they have a sequencing by which we can differentiate actual healing versus a disease progression by comparing.
So the jury's out on this, and I'm glad you're doing this work, but I think at this point, we still need data to convince ourselves. And again, PET scan is a high radiation, high expensive, so it shouldn't be the thing given out that, do PET scan for everyone with TB. And maybe once you get your data out, Tushar, we'll have some more benchmarks to go by, that in which case a PET scan can bail you out when you're stuck in terms of healing.
Dheeraj, any particular thing which you would like to add on a braces? Kshitij mentioned about the Miami and CTLS. So both, do you have any particular braces in mind that you give them?
No, something not any unusual brace. The routine for cervical is Philadelphia for me for most of my cervical patients. Maybe a Somi or a Halo in case I need a much rigid support. Halo brace and thoracolumbar Taylor's brace in for most of my thoracolumbar lesion. And only if they are unstable or having a significant loss. If for very early, still I can sometimes try to avoid brace, but these cases are very less in our practice. So most of the patients go for braces.
Kshitij, do
Also,
you?
regarding one more thing, I want to add. You asked regarding the MRI images. So from start to end, that's the one thing, and everything in between is around 6 months approx, which I think most of us do follow. If patient have any new symptoms or aggravation of symptoms or worsening neurology, so in that case we can go for MRI early. PET CT, what as the so in only in cases where we are not sure whether we have to stop AKT or continue AKT. In that cases, we might be doing. So these are maybe 2 to 5% of our whole patients. Otherwise, we don't need. Right.
Kshitij, last question. Do you brace till them end till end? How's your bracing this thing? By the time, Rohan, can you take that question? Kshitij answers.
Yes, sir. I don't brace them till the end. I don't think that you need to brace them till the end. Maybe, as he said, a lot of it depends on your clinical serology and radiological evidence also, along with the moment the patient is doing well, and he himself will tell you that the pain has come down significantly. He has a sense of well-being. All these things actually help me to actually wean him off the brace rather than continuing bracing. Yes, we have to be careful in the initial 3 to 6 months, I would say. I was going to say 3 to 4, but I will just extend that to 6, but not until the entire treatment. I feel that is too much. I feel.
And there's a lot of discussion with respect to vitamin D as a anti-tuberculous property. Is there anything that you?
So I have no idea on that.
Okay. Now I would like to invite Dr. Abhay Nene for the last talk, which he gonna be talking about the surgical management. I think Dr. Abhay Nene doesn't need any introduction, but he has been always there as a senior teaching senior faculty who guides especially about this kind of a disease pattern and what is his protocol. We would like to understand with this particular talk. Over to Abhay, sir.
Thank you so much. And at the outset, I must say that whatever you've heard so far is the hardest part of the webinar. And being the older guy, I get the creamy part to talk about. So thank you for giving me this opportunity to talk about surgery in tuberculosis. We are the best experts in the world in tuberculosis, but these are some of our cases that have gone horribly wrong despite surgery. And trust me, some of these are even my cases. So there's something obviously going wrong. And if we could have an algorithm that could be easy to follow, life would be much easier. And I'm going to try and deconstruct an algorithm for you in the next few slides and even try to talk to you about a few traps that we fall into when we follow basic algorithms. Because as you know, TB is a multi-dimensional disease, and you have to think of too many things before you actually can just sit and plan an algorithm. So we already heard that the commonest causes for doing surgery are these many. Neurology, of course, bony compression, you were told. Unknown diagnosis rarely, deformity and instability. However, the goals of surgery remain the same. No matter what the indication, you have these goals. The first typically is decompression, which is optimum, not exaggerated. So unlike removing a tumor in tuberculosis, you just have to remove the offending area, which is often the middle column. You don't have to excise TB. You have to just decompress the neural structures. The next important goal is to get enough material for tissue diagnosis. The third is to reconstruct appropriately and then fix and stabilize as much away from the infection as you can, and then back it up with correct AKT. If all these 5 are followed, you're normally, nailing it just the way you. As a surgeon, I would want to look at 3 variables when I see a patient with a spinal tuberculosis as seen in this MRI on the top right. I want to see if the lesion is wet or dry. I want to see if there's kyphosis that needs to be corrected, not just the presence of kyphosis, but is there kyphosis enough that needs to be corrected? And then I want to see the patient per se, how old, how morbid, and what are the how high demand or low demand the spine is. And then we fall back on the classification of who we call the god of spine, Dr. Bhojraj. The simple classification published, more than almost 25 years ago, which gave us these 4 varieties. And this is a very simple thing to follow. It's out there now, available on most internet resources. Um, it divides TB into a very simplistic manner, and by and large, this is a good footprint to follow. Of course, the type 4 is the rarest, but the easiest to deal with. When there's a pure posterior lesion, I think it's a no-brainer. Go and decompress from the back. A surgery all of us are very fond and capable of doing. And however, unfortunately, this is not how TB presents commonly, and a posterior element lesion is extremely rare. But if you do get one, identify that this sticks within the lamina and the TB is not overflowing into the facet joints and into the weight-bearing structures, and they just take off the lamina, decompress, biopsy, and then start AKT. The more common presentation is when there's an anterior disease. Now, when there's an anterior disease, the next thing you want to ask yourself is there kyphosis? And if there's no significant kyphosis that needs correction, anterior alone surgery, a direct approach, a direct attack surgery becomes one of the good ways of doing it. Here you have minimum kind of reconstruction needed, just the bare minimum. You don't retract the cord, so the chance of neurology going wrong is next to nil in these surgeries. And of course, you in the end get a graft that's under compression where you really need it rather than at the back. So it's got too many green ticks, except the fact that we are less and less trained to do it. And the newer generations are less and less trained to do this anterior approach. And that seems to be a dichotomy in our system, though we are treating so much TB, which should have been the training ground for doing anterior. That's where we all learned anterior surgery. I think less and less people are learning anterior surgery, and somewhere we need to fix this draining pipe. The question that comes is, after doing anterior surgery, would you put a cage or a graft? Back in the day, the graft was the gold standard. You take a tricortical bone graft from the crest and push it in, and that's that. So the picture on the bottom right is one from Dr. Bhojraj's case in KEM, which is in the late 80s, and they fuse beautifully. It's good to do this non-instrumented bone graft, especially in the mid-thoracic spine, which is inherently stable. You may be found wanting if you do this standalone graft in the lumbar spine. Nowadays, cages have been acceptable, so there have been enough studies to show that putting a titanium mesh cage in the middle of active disease is also all right in tuberculosis. And hence, many of us now prefer the cage to avoid the morbidity of a graft. The advantage of doing this in the lumbar spine, a direct attack standalone anterior surgery, is that you save motion levels, which means that you will get to do this surgery and fuse only that motion level that was in suspicion. So here's a case of lumbar spine TB, again treated with a pure anterior graft. Of course, this patient was protected. These are all cases from my boss, Dr. Bhojraj, done in the late 80s and early 90s, and they've stood the test of time. But remember, these are extremely technique heavy, which means that you should have the right technique, have the right appetite to do this operation. Otherwise, you should not be doing it. And many of us newer generation surgeons do not have the appetite to make that access, to harvest a good fat graft, make it work, tailor make it for you. And hence, sometimes you don't want to do it. Now, where does this pure anterior surgery fail, which is otherwise a gold standard approach? So one of the causes is where the surgeon misappropriates the instability, which means that if, of course, this is a case of GCT, but I'm just putting it here as a case of pathology of a bone. Here, the surgeon misappropriated. This case was operated in one of our municipal hospitals. And as you can see, there's a middle column and a posterior column involvement also, and that was completely missed by the surgeon. And so there's nothing protecting this anterior graft. So though the surgeons put in the graft with a screw and a rod, it's bound to fail because it's going to windshield wiper its way because the posterior column is completely gone away. So if you get a case like this is not the operation that you do. So the takeaway here is that if you're planning an anterior surgery alone, then be very vigilant of the, the continuity of your posterior and the middle column, and then your anterior surgery will survive. Now here's another case. This is my case. I operated this back in the day, and it was a kyphosis is a young girl in tuberculosis, and I corrected it pretty handsomely, I thought, with a pure anterior surgery. But once again, though on the MRI, you will not find any defect in the posterior column. As is famously said, the posterior column is physiologically failing because of the kyphosis. The posterior column is not holding its own. You see the interspinous widening. So this was I'm going to say a day one failure. The minute you do a pure anterior surgery without adding a posterior column tension band, this is going to fail. The other cause of an anterior surgery failing is, of course, suboptimal disease control, and you can't hear enough of that, which means that you do a nice flashy surgery from the front. Again, this is my case. But again, this was back in the day when MDR was not common, and we were so happy with the outcome of the surgery that we didn't even chase up the report of the culture, and it actually turned out to be MDR. And until she came back with recurrence of disease or rather, inability to heal, we found out it was MDR. So it was technically a failed anterior surgery. Now, here's the second scenario where you have an anterior disease, but no kyphosis correction is needed. But this patient is not a patient who's fit for anterior surgery. And this is, of course, a fine line. I mean, there's a gray zone. Fitness for anterior surgery is really a, myth. But if you find that the patient is high comorbidities and low demand, you could do a posterior alone splintage surgery, which means you go from the back, your familiar quick approach, put in a lot of implants, fix the back, and then go around and just take away the middle column, which means you're not bothering to excise the anterior column, nor are you bothering to reconstruct the anterior column. This is called the transpedicular decompression, which is so popular in tuberculosis because the middle column is invariably affected by soft tissue rather than bony tissue. It's very easy to remove this, and it's very easy to leave the anterior column, which will then reconstruct itself over time as the TB medicines act. So of course you can't do this surgery in tumor because the tumor is not going to be responsive to chemotherapy. So in a tumor, you want to go and excise the tumor. In TB, you can leave all the parts that are not causing you a problem and hope for them to be reconstructed by, by medication. We often use the Hartzell rectangle, which is a spinal loop rectangle with sublaminar wires. The distinct advantage of using this implant in this scenario, a low demand patient with no kyphosis correction, whose anterior surgery is contraindicated, is it allows dynamic gliding, which means that if your implant is not rigid at the back and you've not reconstructed the anterior column, it will allow the column to settle in until it fuses. And of course, it's an extracortical hold, which means the pull-out strength of this construct is far better than that of screws and wires. This is how it's technically done. You do a laminectomy, which is wide enough from pedicle to pedicle, go around the spinal cord, and then without retracting it, and then open up the middle column and then fix. And it's easy to do this surgery if you learn T-lift in the lumbar spine. It's like pushing that T-lift to the thoracic spine to approach the cord without actually retracting it, to approach the stuff anterior to the cord without actually retracting the cord. So here's a case in point, and you'll find a dime a dozen of these immune compromised senior citizens who get this kind of a disease. Just imagine if you had to do an anterior surgery here, you would be found wanting, because you're doing a mid-thoracic or a high thoracic approach and taking away 3 bones or maybe 2 bones and leaving a big gap for reconstruction. This is a quick, easy 1 hour or 15-minute or 1 hour 30-minute operation with great reproducible results, which you can do even without using a C-arm, if you may. So it's and the entire inventory of this implant is like equal to 1 pedicle screw, like 10,000 rupees for the whole implant construct. So it's a surgery that can be done across the board. Now, where does this approach fail? So the trap here is that when you're planning a transpedicular decompression with an in situ fixation, it fails in these 2 scenarios. One is that where the kyphosis has been misjudged by the surgeon. So here's a situation where, and of course, the second is with a growing spine. So I come back to it because this case was a growing spine also, and the kyphosis was misjudged. Again, this is one of our cases. Again, this is done, if I'm not mistaken, in 1982 or 1983. That's really long ago when there was no pedicle screw available, especially to be put in a child who I think this child was 3 or 4 years old. So we fell back on that Hartzell rectangle, which is timeline to fail. Again, this is a case which is done today. Like this was done in the last 3 or 4 years by myself and Dr. Arjun Dhavle in Wadia Hospital. We had everything at our disposal. We really don't know what to do. It's a cervicothoracic spine in a very small child with a significant, almost 80-degree kyphosis and a lot of material that needs decompression. Here to do a transpedicular decompression was mainly for the want of anything better. There was not many other options that we could think of. So we just went around the cord, decompressed, put tons of bone graft. But as you can see, the kyphosis was too much for this kind of a fixation from the back to manage. And this is going to fail. And not that we have an answer to this, but I'm just trying to draw out why this fails. And if you have a lot of kyphosis to correct, you want to then change your plan and do one of these 2, which is one option is, of course, to do a back plus front surgery, which means you correct the kyphosis. Like in this case, if you could have corrected the kyphosis and gone in the front and put in the large graft, I don't know from where to where, but this wouldn't have failed. And so if you can do that, that's a great option. So the option of posterior plus anterior surgery to save levels. When you have an anterior lesion where kyphosis needs to be corrected, the other option is do a posterior alone approach where you actually close the kyphosis, which means you biomechanically align the spine by just closing in on the wedged bone, or you reconstruct the anterior column from the back. So these are the three options that come up in that typical case of tuberculosis affecting the anterior and the middle column with neurology and kyphosis and instability. So back and front is your easy approach, easy friend. It's ideal because you're decompressing from the front, fixing from the back, the best of both worlds. And you get a full 360-degree fusion, and you get a long posterior lever arm to correct, and there's no cord retraction. However, it's a long drawn out surgery. So sometimes you feel you're overcooked it, you're doing too much for a disease that otherwise is very surgery friendly. But this is the surgery we used to do often in the past. Less and less today. However, in the lumbar spine, just remember it will save you levels because you can get away with a 1-level fixation if you did a good, strong anterior reconstruction. So if you're able to do it, I think that's still a great approach. The other option is a pedicle subtraction osteotomy, which means that if you find a case like this where there's a kyphosis, there's, the bone is collapsed in the space of the disc, you could then, take away that disc or take away the wedge of that bone and then close it down like this. And you've physiologically reconstructed the anterior column by shortening. So there's no gap left in the front. That's the key. If you can restore the biomechanics and not leave a gap in the front, your posterior implants are not going to fail. But if you do either thing wrong, your implants are going to fail. That's how the transpedicular approach is done. It's not so hard. You go through the pedicles, take down the facets, go through the pedicles, and then core out the pedicles, which are often softened by the disease, and then shut this down. And this again is a reproducible approach. The way to learn this is to do transfacetal approaches first at the lumbar spine, even for discs, and then move to the thoracic spine, and then move to transpedicular. So there's a slight difference between going through the facets and going through the pedicle. Pedicle requires you to actually work within the pedicle and then core out the pedicle and then crush the bone, while transfacetal is actually exactly like doing a T-lift. And you can do this using a multitude of implants. Now, where does this approach fail? This is one of our workhorse approaches today. And mostly we do most TB spine cases with this approach. But it will fail if your bone stock is poor. And remember, a bunch of your patients will have poor bone stocks. So this guy, we aligned his spine. We thought we'll get away get away quick by doing a quick job. But you can see the screw is on its way out even as we put it in. And if the bone stock is weak, think of spinal loop rectangle with sublaminar wires, or think of going super long. I'm not a great believer in cemented screws, so you'll have to have a biomechanical ability rather than make a guess on cement. And of course, it'll fail if too much kyphosis needs to be corrected. Now, this is again one of those challenges we get at Wadia Hospital every few weeks. Very difficult to handle. So if you have a lesser kyphosis, this will work. If you have a mediocre kyphosis, thoracolumbar spine, like 50-degree kyphosis, you're on the edge. I'm going to say if you're doing this approach, a pedicle subtraction osteotomy here, it's going to be a plus minus, hit, miss. Maybe, you want to supplement this with an anterior reconstruction, especially in a growing child. But in this child, this approach is not working. And if you can, take a hard look at the X-ray, we have put in a fibula graft. We've tried to wedge in a fibula graft, but at this level, with so many bones destroyed, thoracolumbar spine, this is not working. And this child, sure enough, gave way after some time. Also, it fails if the anterior bone defect is too much. So if your anterior bone defect is too much, especially if you don't have a bone-on-bone available like this. So here, if you do a subtraction osteotomy, you're left with just a disc space in the middle. It sometimes makes sense to reconstruct that anterior column from the back, and it sounds difficult, but actually quite a straightforward procedure. Once again, repeating myself, you just do that T-lift approach, as you can see on the top video. And Tushar, this is the case we did in KEM, in the workshop, and you shot these lovely videos, and I use them again and again because they've been so beautifully shot. So you just go lateral, take the facet down, walk into the pus. It's all bad tissue. Just create enough environment in the front, which means enough bone support. You don't necessarily have to take out tons and tons of tissue. Just create a good spot for the cage to fit in, and then put in your cage from the back. And these cases where a pedicle subtraction osteotomy would leave the anterior tissue hanging free because they're just disc on disc. These cases you want to do an anterior reconstruction from the back. And the art of learning this is through T-lifts. It fails if you're not good enough. So this is one of my first cases I did in Hinduja, where you can see, it was very hard to get that cage in and it's hanging around. But TB being such a forgiving disease, we have a 20-year follow-up on her. The cage is not still gone into the aorta and she's still surviving. Here's another one where we try to do a posterior reconstruction from the back, only to realize that, we are working against the anatomy. And you have, again, this cage hanging very precariously, but again, this patient got away, without too much. So my take-home messages would be, if you're thinking of surgery, look for kyphosis, look for the patient profile, and then decide what you want to do. Of course, look if the lesion is wet or dry. And then this is the final algorithm where if you're doing an pure anterior surgery, don't miss posterior instability. If you're doing a surgery of a back and front approach, be ready for hard work and master the technique of the anterior surgery. And if you're looking to do an all posterior approach, just watch for that kyphosis and don't miss correcting the biomechanical axis, getting a good long fixation and a good reconstruction if you're leaving a space anteriorly. Thank you so much.
Excellent talk, sir. Excellent. I think Dr. Abhay covered everything in detail and with a lot of examples. And most important, he showed the failures which can occur and which are, I think, in everybody's hand, and we all seen that kind of failure happening. Since sir, you covered all those things, and the common problem that we as any beginner sees is the edematous end plate, this cage place getting displaced or cage getting subsidized. So is there any way by which we give a AKT first, wait for a few days in this kind of grossly where neurology is okay, we can wait for some days and then intervene, or you don't think that waiting and giving AKT?
Yeah, I don't think a wait and waiting, because the goalpost just keeps shifting. You don't know how long to wait for the bone to reconstitute. And typically, if you wait, they become non-surgical. Trust me. So if it's surgical on day one, you just do the surgery and then accept that you do it correctly. So what I mentioned, that you don't have to go from a predefined area. When you go in, you just create a good bone, bone surface on the top and bottom. Doesn't matter where it is, and then slot in something. You don't have to necessarily remove X amount of bone or X amount of tissue. Create a good slot, just fill that in like a bridge, and then you're winning it.
I think it's a very important message. You don't need an end plate to end plate reconstruction, which we think like looking at Western literature, but it just, and he always say that because he has come a lot of time and operated on a live surgery in a workshop. He always, the words that he uses, only remove the structure which are offending and leave everything, because everything ossifies with AKT. You just take out the offending structure, and that I think should be the aim of any surgeon who is venturing in this kind of a territory where there's a lot of destruction, and the cases, the profile which is showed is a very complex cases.
Also, Tushar, maybe you should plan this on an X-ray rather than an MRI, because an MRI will freak you out because all the bone looks white and you start worrying. But an X-ray will really tell you whether the bone is, constitution of the bone is good enough to hold your graft. So don't walk into the trap of planning this surgery based on an MRI scan.
So I always feel one dilemma is that we see a lot of young kids with a lesion around L4, L5 with a destruction and with minimal collapse. Sometimes I feel because the way to go ahead and do this is to go from L4 directly to S1 and fuse them so early. Is it okay that we accept this amount of kyphosis in these young patients, L4, L5, and maybe
So it's a good challenge. Yeah, it's a challenging situation. But what we've been doing nowadays is splinted surgery, which means that if you see them going into kyphosis, we don't fuse them. We just fix them from the back, biopsy them. And, once the bone reconstitutes, go take away the implants. That sometimes works if you're early in the game. Yeah.
Okay. Okay, nice. Dheeraj, Rohan, any questions, Dr. Shakir?
So I have questions, sir. Excellent talk. Sir, you have a paper. So you have, I think, made a algorithm or a flow chart to decide when to go for an anterior surgery and when to do only posterior based upon the amount of vertebrae which has been destroyed in thoracic or lumbar spine. Can you tell this in brief how you decide on?
Yeah, because these are just guidelines. These papers are such clinical papers, that I don't think we can, they don't prove any point. But the guideline is that if there's a large anterior defect to be covered, or if your posterior surgery is going to leave a defect at the end. So if you're correcting a big kyphosis and you're going to leave a large anterior defect, then it's better to have that defect covered. Now, if you're not able to cover that defect from the back, which means that your skill sets, for example, in the lumbar spine, you can't cut the roots. All the roots are like in front of you. You sometimes will have to go in the front. So I think I'm not able to really give you a packaged version of this, but all I'm saying is that if your anterior column is found, reconstruction is found wanting from the back, just don't hold back, just go around and do an anterior fusion, because the more of those you do, the more you'll realize you get a far better fit from the front. And it's just unfortunate, I think Tushar and Dheeraj will agree that the new generation, Rohan, you're the new generation, and you have to prove us wrong. That the new generation is just not listening to anterior surgery. They're just not. They're just going farther and farther away from the anterior surgery. And someone needs to be a Superman and revive the anterior approach because it's so important in our life. You may have to do it just once in 2 years, but when you have to do it and you don't know how to do it, you're just going to fall flat. And ultimately, you're a spine surgeon. I mean, that's all you do. You can't afford to say that I'm a posterior spine surgeon, right?
Is there any role of now, because the anterior approach, the most contentious topic is the Dr. Kshitij, in your practice, what are the cases where you had to go anterior plus posterior for tuberculosis spine? And what is your thinking about the anterior approach?
So anterior approach. So the last time I think we did anterior approach was lumbar tuberculosis. So when you have a very lot of destruction in the lumbar spine, reconstructing it from the posterior approach with the roots in between, it is possible, but it is a little bit tricky. And those people who can do an anterior, for them, it is no brainer to go from the front and remove it because it is very easy to do it from the front. From posterior also, you can do it all posterior, but technically the surgery gets more difficult because you have to save the nerve root. So that's one place where it is anterior posterior. And then sometimes you have a significant amount of destruction, even in the thoracolumbar or thoracic area, where I have done an anterior posterior, where, I mean, to break the posterior column to such a significant extent just to reconstruct 3 or 4 vertebral bodies in the front. I mean, we don't see those cases, at least in my practice anymore, but in KEM, I remember, doing, I think I have done a 5 or a 6 level thoracic vertebral body reconstruction, like anterior posterior. Because, imagine putting it like such a big reconstruction from the back. So cutting off so many nerve roots. So anterior posterior in those extensive situations is probably okay, but I think most of the cases you can get from the back. The other area where I'd like to do anterior is the low cervical area, where T3 or T4. Sometimes you can get those from the front as well, but not everybody is confident of operating in that area just above the mandibular notch. So, many people would prefer from doing it from the posterior approach, which is completely fine. But that's one area where I kind of prefer doing an anterior, a low cervical approach and getting, I've done a T3 also, a corpectomy from the front, or a T4 sometimes, rarely, because that requires a very long neck.
Yeah.
But otherwise, yeah, most of it is posterior.
Abhay sir, you showed a lot of pediatric cases with a large defect, and I see I showed a fibula case because the bone graft is always the issue. So is it a common graft that you always like to use, fibula?
Bone graft and rib. These are those cases where you suddenly have 5 bodies gone and our posterior implants don't have such good hold. So we are forced to using, actually back in the day, we've even used mother's fibula. That technique has gone off, but when I was a postgraduate, Dr. Tarapurwala had actually used the mother's fibula was excised and put in without sterilizing, without any, just a blood group compatibility, that's all. So fibula is a good graft to use, yeah.
In general, given a choice, mesh cage vis-a-vis tricortical graft in adult dorsolumbar junctional tuberculosis.
I think adult always cage because you rarely ever use a tricortical graft, but kids actually it's a bit different because the bones are so small.
Pediatric is one place where if you have a choice, you would do an anterior posterior, because that's one kind of a column where you don't want to break the intact posterior, because that's the only thing that you have that is holding this whole column together. So you don't want to do like a multi-level facetectomy, pediculectomy, and then go from the side and reconstruct. And also pediatric is one place where if given a choice, I would do an anterior posterior. I will not touch the posterior at all. Posterior is just to splint, wire it or screw it or whatever, however way you want to hold it from the back, but then go in the front and reconstruct it very well. Fibula is kind of quite good. And we have done the baby's fibula, the child's fibula, taken two fibulas together, wired them together so it becomes bigger diameter, and then put it together. So that's, but yeah, cages for pediatric are problematic. I'm not sure you find such small ones.
Other thing which Dr. Abhay highlighted, and that is especially for a youngster, is that don't think of just doing a minimal fixation. If you are in doubt, if there's an antibody specifically mentioned, don't do single level fixation. At least give a support in a front and go longer. If you are in a doubt, never be short. That is also an important message, which I think is very important. Now,
And you can always fix long and fuse short if you don't want to fuse long.
yes, I agree. We have a few two cases to discuss. Quickly, I'll request Dr. Bhushan, who is an assistant professor at KM Hospital, to present his case. Bhushan, you can share the slide.
Yes. A very good evening to all the faculties. I'm Dr. Bhushan. I'm currently working as assistant professor under Dr. Tushar Rathod at KM. I would like to present the case of spondylolisthesis of a dorsal-lumbar junction. So this patient presented to us when she was 7 years old. She presented with back pain, which was of 1 month duration with a progressive deformity of 4 months duration. She had no neurodeficit at presentation. She was started on antitubercular therapy, empirically looking at the picture, 2 months prior to admission. She got admitted with us in June 2017. This was 2 consecutive X-rays that were done like 2 months apart. On the left, you can see an X-ray done in June 2017, while on the right is in August 2017. So the angle has considerably changed from 30 to 40 degrees in a period of like 2 months. We further went and did an MRI for her, where we can see that there is destruction of the L2 vertebra. There is prevertebral abscess, just tracking almost 2 levels. And the axial, we can see there is subligamentous abscess collection, as well there is collection in the psoas. So the case is open to discussion. Sir, I would like you to give your opinion about how we should address this growing spine. Then how what should be done for the kyphosis and the coronal plane alignments scoliosis? Would you do a conservative management or operate go and straight away
This
operate?
case is, how old is she now?
So, she is 13 years old now. It's like 7 years post-op, sir.
Okay, so just a disclaimer, this case, Dr. Abhay had operated, I think he'll remember as he'll see the X-ray. We had done this in a course and we have one of the like 8-year follow-up of this case. 2017 we had operated, you had operated with this thing. So at this point, because Dr. Abhay had already, we are going to see his plan, but I would request Shitish to say how would he outline this particular child. 7-year-old child, can you go back to X-ray and MRI?
And the first X-ray only is not good. So this kind of deformity is going to be a progressive deformity in a child. So there is no conservative treatment for such kind of a column in a child. One side is destroyed, the area is kyphotic, the vertebral body is like behind those lines that, you know, when you draw at the back. So this is an unstable situation. You see the facets opening at the back as well. So with this child, it will be surgery. So it will be reconstruction only. You can do it all from the back, or you can do back front as well.
Okay. And how many levels would you like to see?
So pediatric patients, I don't think doing one level, one up and down is going to be sufficient, because those pedicles might be strong, but it depends on your purchase. You try to remain short as much as possible, but here it may be hard. So it will be 2 up, 2 down, and reconstruct the whole hog.
Okay, and you'll be using the laminectomy graft, or which graft for the?
You use a structural graft in the front, whatever, to reconstruct that front graft. So either you can use a cage or fibula, or whichever graft you prefer to use.
Okay.
7-year-old, not really very small. So this is possible to reconstruct. It's the under 5 that are problematic. Very small, under 5 will be tricky to do. 7-year-old is possible to do.
And what would you be doing for this L2, L3 disc? You will be taking out this disc entirely, right? L2, L3.
Reconstruction means end to end plate.
End plate to end plate. Dheeraj?
So yes, So in this patient, I will like to preserve the level. We have to go for a fusion surgery because it's an unstable scenario. And so for me, anterior reconstruction is must. So I will like to go one level down and two level up maybe. If I'm not happy with the fixation down, I may add up few. Along with that, to increase the anchor, I may add some sublaminar wire.
Okay. Bhushan, can you show the X-ray?
Yes.
First X-ray.
Okay. First,
Any first X-ray? You don't.
yes.
Any plan to convert the pedicle at the affected level and take the other side down, Dr. Kshitij or Dr. Rohan?
Not very useful.
But I would not sacrifice
Uh,
the I wouldn't. I
You
mean,
will what?
uh,
You mean
I think that it's a good idea because it will help you to correct some kyphosis. Also, we will have some hold over the posterior elements of that particular disease vertebra as well. And you can preserve the one side of the posterior element as well as pedicle and have a fusion bed on that surface also. So that is absolutely okay for me.
Rohan?
sir, no sacrificing. This patient was intact at 7, so I wouldn't even touch the spinous process or the lamina or do even a laminectomy because on position, whatever I try to get, I would get. On the coronal, you saw that there was asymmetricity because the collapse was more on the left. So I would do all my work, only fastectomies and everything, and whatever cage work has to be done will be only lateral work, preserving the tension band in between and splinting two up to down.
Lateral work means how would you approach Olive, like Olive?
No, sir. I would just do a transfacetal / transpedicular decompression here and then put in a cage. Yeah.
But you will do the laminectomy portion, right?
No laminectomy, just wider. Just preserve. I would not take out the spinous processes and go in. So this is what I was going to come to. Okay, even as all posterior surgeons, what additional advantage we get by going pure transfacetally now is that we just burr out the facet from the lateral aspect. Now, once you burr out the facet, you just go anterior to the cord and you can see the cord from the side. That way, what it allows you is you don't have to do that unnecessary posterior decompression because the disease is never posterior. So even if I attack everything from far wide, let us assume we go even more radical, not in this case, but in general. Let us assume we do a costotransversectomy. I would still not disturb the posterior band because a costotransversectomy still will allow me to go anterior.
But this is kind of a lumbar spine. So we have
so this is separate, but I'm just telling you that preservation of a posterior band helps the posterior.
Dr. Kshitij mentioned 2 level above and 2 level below. Do you always keep in mind regarding the implant removal also in these cases, or you don't think about it in this case? 7-year-old.
In so much of a deformity, once it heals, it is no, sir. No.
It will be, it depends kind of correction. So you cannot be adamant that I will not do the other side or I will always preserve, because it all depends on how this is going to correct. If this is super wet tuberculosis, everything all in place, then what Rohan is saying will work. But if it doesn't, then you will have to release. Then when you start releasing, then you are releasing both sides.
Yes, sir. Yeah.
Only everything will correct.
Yeah.
So you can't just assume that, okay, I will be able to get away. But yes, what Rohan is saying is right. You will try not to disturb as much as possible. But if given a choice, if it is not happening, then you don't have a choice. No, then you'll have to knock things off to just correct the kyphosis. There is no point doing surgery and fixing this patient like this.
Yes.
Tushar,
So
I can add something. Just quickly. In this patient, one thing is a practical issue for the operating surgeon is that the approaching area for a neuro intact patient is absolutely narrow, especially on the concave side. So if we try to prepare the end plates and take out the disc up and down, so it will be a huge void, and reconstructing that through that on the concave side, to the fasciectomy, what we do on the concave side will be a challenge. In that, we have to go for a more aggressive procedure, which most of us may not be very much comfortable. Hence, only a posterior surgery also is one of the options.
Maybe a posterior surgery with an impaction bone grafting. I don't know. Yeah, something like that.
no, this will be proper reconstruction.
Antecolumn reconstruction.
This pediatric patient, you don't have choices. You cannot
Right.
make that kind of thing for pediatric. Pediatric patient, the better you reconstruct on day one, the better this child is going to do. If you are
Right.
going to tell yourself, "अरे pediatric patient है, heal हो जाएगा."
The
दाल
neuro intact is there. The place
हो
for a
जाएगा, नहीं
preparation is very narrow, so it will be a challenge in that
होगा.
case.
These pediatric patients are the most notorious patients to have a problem.
I'm
So
purposefully not,
construct it like a proper with lot of attention to detail. This cannot be pediatric है तो कुछ भी bone graft डाला तो चिपक जाएगा. ऐसा नहीं होने वाला.
very important. I'm purposefully not asking Dr. Abhinay's opinion because we're going to see what he has done. This is the case which we had done a live surgery. Bhushan, can you move ahead? And if there are any question, you can ask.
So that is what I was going to ask, sir, like whether we should biopsy or then operate, then the choice of implant regarding pedicle screw or hard shell, then again anterior column reconstruction, which already sir has told a lot of things about it, all posterior approach or anterior plus posterior approach, then again which side to be approached, only the destroyed side or we should release it both side, and then the laminectomy extra. So this was the the two-level instrumentation was done, two above and two below, with the reconstruction from the left side.
So Rohan,
And-
any comment?
No, sir. I'm okay with this. I mean, this is a very good.
Bhushan, you have any things to say?
So we biopsied this patient and it came to be XDR TB. The heterop samples were sent and this patient turned out to be XDR TB. To start it, she was started on sensitive AKD, but then post the surgery, we shifted her to XDR AKD.
So this is a pediatric system. Is beautifully reconstructed from the affected side. Other side has been kept intact. The cage has been introduced from one side, in plate to in plate. Dr. Kshitij, what is regarding the rod contouring? Are there anything specific that you keep in mind when you are dealing in this area?
I think this is fine. It should be lordotic, but I think this alignment is totally fine for the upper lumbar spine. And this the X-rays are taken lying down, so this won't be a true measure of how it looks when the patient stands.
Subsequent follow.
But I think this is like a fair result. I would have accepted it if I would have seen this as my last X-ray. I would not remove the rods and try to make it more lordotic and all. This would be acceptable to me.
Yeah, because eventually we're using the upper lumbar spine. So I mean,
Yeah, it's upper lumbar spine. This is fine.
Right.
So the patient was serially followed up, sir. On the left, we can see 1 year follow-up at the start of the year, and on the right, it is the 1 year follow-up at the end of the year. This is the second year, 2 years post her surgery in January 2020 and December 2020. She is doing fine. We
So
can
now
look at
we are seeing the X-ray of 3-year follow-up. Are you happy with the X-ray? Anyone has any comments? Dr. Abhay sir, now he can pitch in.
Sorry. No, I mean, here, of course, the thing about fusing short and going long would have been an option. And I think so far it's good. The worry is, of course, that the lumbus is the fastest growing area of the spine. So will the implants give way, above and below especially? But so far, I think it's held on.
3 years they have hold on very well. Yeah.
I think this will do just fine. And then so many scoliosis patients we fix to L4, right? And this would be something like that. Thoracic spine is completely fine. So if this would have been a lumbar Lenki 5 curve, it would be like this. For a say 10-year-old. She's 10-year-old, right? 10, 12
Now
years.
she's 10 years.
Yes.
She was beginning to with 7, now 3 years follow.
Like those kind of people. So she'll be fine, normal.
Go ahead.
So in 2021, she started having superficial surgical site infection. We did an MRI at this time to rule out if there was reactivation of the tuberculosis, but the MRI showed no abscess. Unfortunately, the patient films were lost to follow-up. But then the note says that there was no reactivation of tuberculosis. It was a gram-positive bacilli that was gone. And then it went ahead and did the implant removal in October 2021. This is the immediate post-implant removal X-rays.
So 3 years down the line, she had this infection. She is please mind this was a XDR tuberculosis. So we had a very high threshold that is it a reactivation or not. We sent the sample. We did not get it. He is getting all the films now from this thing. And this is so we decided that it's a superficial infection. We decided to do an implant removal. Was it a good choice or was anything else would have been done by any panelist?
Sir, on table integrity of implant should have been checked. I mean, if they were not
Yeah,
loose,
CT scan was done. It was there was a good fusion mass, and there was a infection which was going up to superficial. MRI didn't show any deep this thing. So
would you have removed? I mean, to the other panelists, I mean, would you all have preferred removing this implant in the first place? I don't know.
Yeah, I mean, why not? I don't see the implant is a problem. Like, if the implant is the reason for this infection, remove the implant. It is so late in the surgery.
yes,
I don't think implant is functional in this patient after 5 whatever years have gone by. So, I mean, implant is not doing anything. So if that's the reason for the patient getting a sinus, take it out.
Yeah, we thought so after ruling out.
That's the easiest way to solve the problem, because implant exit antibiotics is 2 weeks. With implants infection, antibiotics is God knows if you want to retain the implants. Best if this sinus is still the implants, get it out, give antibiotics for 2 weeks, and story is over.
Same thing happened, I think. Bhushan, can you go ahead?
So this image shows how the sinus healed after implant removal. This was immediately like few months after the implant removal, and this was the 1 and 2 year post the implant removal follow-up. So that's almost 6 years post her index surgery. And this is the exit X-rays. This is on the right we can see when she presented to us in September 2024, and this was after her implant removal in 2021.
So
that's
go
how
back
she
one
has.
slide. Yeah. So Abhay sir, we have this follow-up 2023. Now she's absolutely asymptomatic. Followed up with X-ray. We got a good fusion mass. Any comments?
I think hats off to this team, yeah, to follow up a municipal patient for so many years.
We
Our
followed
private patients don't come up so much, so I think hats off to you all.
Oil.
It's a
Data is
very
the oil.
fantastic outcome I wanted to show you, because it was a very bad disease to begin with. We had a good fusion mass and she did very well. Now she's a completely grown-up child.
But you know, the surgeon takes undue credit here. I think the person who's managed that XDR AKT,
Yeah.
Shah, whoever it is, they are the ones who really deserve the kudos. It's extremely hard disease to manage.
Yeah, that is modesty, but sir, yes, this is also the reconstruction 2 level. And I think she was lucky to have a good fusion mass and a good alignment at the end to finally land it with. So this is are there any further slide, Bhushan, or you go on next slide? Because
This is
like
the last
of time, yeah. Deepika, can you share your last presentation? This is just a problem case and we would like to have opinion. Dr. Deepika Jain is a senior resident working with us.
Good afternoon.
Please go ahead.
Sir, am I audible?
Yes, please share your slides.
Yeah. Good evening, one and all. I'm Dr. Deepika Jain, senior resident with Dr. Tushar Rathod at KM. I'll be sharing a case of dorsal spondylodiscitis. The case is open for discussion. So this is a 39-year-old female who had mechanical back pains.
Deepika, we need to share the slides.
Okay. Just 1 second, sir. Yeah.
Yeah. Yeah. Yes, we are seeing your slide now.
Yeah.
You can.
Yes. So this is a 39-year-old female with history of mechanical back pains in the past 2 months. And suddenly, within 2 weeks, she developed an acute onset inability to walk and lost power in all her lower limbs. The patient had involuntary movements that she noticed over the next 2 weeks and has history of past KOCH'S contact. So on clinical examination of the patient, this patient is Asia A. All motor power is gone in the lower limb. The sensations is decreased below D8. Tone of the patient is increased. There are human signs. There is hyperreflexia, plantars are going, and the bladder of the patient is involved. And currently, the patient is catheterized. So this is the X-ray of the patient. We can see that at D5, D6, there is absence of disc space and the D5 has collapsed over D6 while maintaining the kyphosis and alignment of the spine. This is the MRI of the patient. Here we can see that we are not seeing the classical wet lesion with with a prevertebral and anterior epidural abscess, which is hyper intense, but a more of a heterogeneous, more hypointense lesion with cord thickness quite maintained, but the anterior and posterior CSF spaces obliterated in the patient. These are the axial films where we can see that there is obliteration of the canal, but the canal is quite maintained yet. This is a CT scan of the patient. Here we can appreciate that on the right side, the pedicle is quite destroyed as compared to the left side at D6, that is a lower level. And there is body loss, approximately 50% of the body loss of the D6 and 25, while the D5 has beautifully collapsed over D6 and has not caused an acute kyphotic deformity. So my this patient, this is a by the panelist who has given the tuberculosis spine instability score. Here we calculated it and it is 7 in this patient, which is the group from 7 to 10, which is impending instability. So this is a gray zone where whether to intervene or not, but the patient has neurodeficit, which obviously tells us that okay, intervention is required. So my question to the panelists are these. I know that the first 2-3 points have quite well been discussed in this webinar. So I wanted to ask about how do you go ahead with the duration of the AKT, the prognosis, like what do you explain the patient relative, like when you see this picture and you are going to go for interbody work and posterior decompression. So what is the type of prognosis you explain the patient that
Yes, sir,
post-op
this
she's going to
prognosis
have?
is always
And
a
what about the bladder recovery in the patient?
prognosis is always in this kind of patient with a dense deficit. So how do you tackle and how do you explain these patients with respect to the prognosis? Abhay, sir.
You obviously want to give them a gloomy picture of anyone who presents with a dense deficit. You know, there's less than 2% of people in the world who actually recover. But between you and me, I have yet to see a patient of TB spine who's not recovered. Even people with flexor spasms and, you know, all crooked and all, you know, completely gone neurologies, even they come back walking after years. So I think she will recover. And I think she's a great candidate for a posterior splintage and wide posterolateral, the middle column decompression, no reconstruction, and appropriate AKT.
Okay, you said no reconstruction because you think the laminectomy and the stabilization would work. So, and the defect is small. That's how
Yeah,
the
and there's no kyphosis to be corrected. And if we are talking of the stable mid-thoracic spine. So you don't want to complicate a very simple surgery.
Kshitij, in your presentation, you also touched upon the hard lesions or those cases we have a dense deficit, but we don't see so much exudative form of tuberculosis. And what we see is that these patients don't do typically well with as compared to those cases with a soft lesion and a gradual onset paralysis. If you see the history, a rapid onset deficit, dense deficit, how do you prognosticate this kind of a lesions, or do you feel that there's no way to prognosticate on these cases?
No, I mean, irrespective of whether it is hard or soft, like Dr. Nene said, prognosis is good. It depends on the situation, like what kind of surgery are you going to do also will make a difference. Like you are doing surgery for internal gibbus and doing a VCR and all, so that's a different completely different surgery. But whereas this patient is not a hard compression. This is, you can see granulation tissue and all. Now, are we sure that this is tuberculosis? Hopefully it is tuberculosis. If it is not, something like this is pyogenic, prognosis is different. So it depends on the condition as well. So, I mean, having said that, if you have like no sensation and complete motor loss and bladder gone, then that's the worst situation. What else can you lose? But you are not going to tell the patient that you will recover. You'll just say that's the best chance that you would recover. And sometimes patients do recover. Without surgery, you have no chance of recovery. With surgery, you have some chance of recovery. So that's how you will go ahead and counsel.
Okay. And what is your experience with respect to bladder recovery in this kind of a patients who have this thing? And what is your protocol when you are dealing with these cases? Do you send them rise at the how discharge? Do you take out the catheter? When do you start your kind of a bladder in this kind of a dense deficit patients?
So dense deficit patients, you can't take out the catheters so quickly, so it will take some time. And you assess it will follow motor recovery as well. So as the patient comes for a follow-up, like, a month or 2 months, and if motor recovery starts, by the time patients start walking in these kind of situations, generally their bladder is also recovered. It follows the motor recovery more or less. But the prognosis for bladder recovery for a spinal cord level lesion with tuberculosis is as good as the spinal cord. Motor recovery happens, bladder also recovers.
Rohan, your plan of action in this case?
The same plan as Abhay sir, but I would just call her back for after 3 weeks for a trial of catheter removal, do her CBC, ESR, CRP, send the tip for culture, see what is the count, so and then decide whether to retain this catheter or not. Mostly these patients come with urge incontinence. My only positivity towards this is also the fact that goes and that recovering because she's still spastic. I mean, despite of she's still hyper reflexic. That is like a first good sign for me. Second is I would also like to see the T1 views. I mean, if you see that cord signal change, which you can see like that extended edema on T1, then my prognosis is slightly towards her not improving. But if I feel that no, there is absolutely nothing there, I would still be very hopeful as the senior consultants here, and I would still feel that she will recover very well. And one more thing I would also like to add, this is a case where I would like to do a laminectomy because there could be an epidural cuff, which is acting as a constricting band here, and that is the cause of that deficit. Because you don't see the CSF flow behind also. Now that can be either due to that subtle instability where the phloem has inbuckled, or it is just the granulation tissue which has formed a constricting band choking the cord, causing the deficit.
Yeah, very well point. I think
there
there
are
are
a
a lot
lot
of cases have constricting. Yes,
You can see granulation tissue on axial images. It's on the side and the front.
No, there is one cut, sir, where it
Can
was
you show the images?
previous presentation. Like there were two axials, of which one of the axials had that constricting kind of a picture. I'm not sure.
Okay, Dheeraj, and before going to Dheeraj, Rohan, would you like to go transfacetal here?
No, sir, a complete lami here. I mean,
Only
because
post-capital.
yeah,
Dr.
because the
Shitty,
CSF obliteration.
Okay. Dr. Shitty, you didn't mention anything about anterior column. Would you go just
No, this does not require like a formal reconstruction. This is very small defect. And you just do, it depends on your decompression. So if you decompress and you find there is a gap in front, then you can do a reconstruction. At the end of your decompression, if you feel that there is good contact of bone in the front, is not much of loss in the front, then you can just leave it alone. But if you are going to decompress and knock off one vertebral body from the back, then yeah, you have a defect there. Then you reconstruct.
Okay.
Reconstruction is additional 15 minutes or max half an hour. And you would rather have a predictable outcome than leave something to chance.
So if you have to reconstruct, what would be your choice of implant? It's just a graft or a cage or a bullet cage? What would
mesh
be
cage from the side?
What is it?
I'll put a mesh cage from the side.
Mesh cage from the side. Okay.
Here, mostly 90% won't be required because the way it looks on the MRI, probably not. So in tuberculosis, you have to be careful about, debridement and decompression. If you start very aggressively, you will end up removing a lot of bone that was not needed to be removed. So you kind of go full on in that disc space and transfacetal, and you will end up having everything in your hand. So you have to be gentle and just do the what is required to do the decompression. Then you won't have a bone loss. Otherwise, you have a bone loss. If you try to put a big curette and scrape things out, everything will come out.
Is there any other question, Deepika?
No, sir.
Yeah, so I think with this last case, this webinar is come to end. I really thankful my panelists, Dr. Abhay Nene sir, who took out his time, Dr. Kshitij and Dr. Rohan and Dr. Dheeraj, and also a beautiful case presentation by both our youngsters, Dr. Deepika Jain and Dr. Bhushan Hadole. I thank you all of you for your patient participation and listening. Thank you, everyone.
Thank you, sir. Bye, sir.
Thank you. Thank you.
Thank you. Thank you all. I'll just end the live stream.
Yeah, thank you, Sandeep.